The main purpose of our Center for Biomedical and Minority Health Research is to address the existing disparities and inequities in healthcare, especially among our underrepresented minority populations here in the United States, and more specifically for us in Harris County and Greater Houston area. We have several research areas here, and my lab mainly focuses on maternal health and child health research in terms of epidemiology work, looking again to close those gaps in health disparities here in our Greater Houston area and Harris County. The other type of research that I do is drug discovery and development research, where we look for new medicines for specific infectious diseases. For example, with the outbreak of the recent COVID-19, SARS-CoV-2 that led to the COVID-19 pandemic, our lab is looking at repurposing some clinically approved drugs to work with the FDA to push some of those to be repurposed for the treatment of COVID-19.
My research is rooted in Texas Southern University and the community around it. So with that, I focus on disease such as cancer, infectious disease, diabetes, etc. And most of them disproportionately impact the minority. And for example, prostate cancer and breast cancer are the two major focus of my research. And they have obvious disparity for African Americans, men or women. So with that, with our nano formulated drugs, we're trying to reduce the disparity and improve the patient compliance. Recently, our work has been recognized as a National Cancer Institute, which is part of NIH. We become one of their subcontractors for preclinical drug development. There are total 19 institutes get that subcontract, and we're the only one from Texas, and we're the only one, the only HBCU get that contract. So I consider that's a great recognition of our work.
Our research is very unique, and we are in the area of gapping the drug discovery toward actual marketing of a drug product. So our facility is very unique, at least in the Texas Medical Center area here, as well as in the state of Texas. That's why we have the CPRIT funding to support our center to provide this type of service. And we have gained a lot of experience as well as a lot of collaborations with investigators across the Texas Medical Center and the state of Texas.
When it comes to disparities in maternal mortality, our country nationally, the United States, is doing really poorly compared to other developed countries. So the work we do is very key in addressing the underlying causes and looking at the root causes of those disparities and poor maternal health outcomes. And so that's what our lab does. We work with a huge center. We just received a huge funding from Health Research Services and Administration to address and improve maternal health in the Harris County and Greater Houston area.
One of the ways that we've seen kind of real-world engagement and impact is through a collaborative that has been born out of the Community Engagement Corps in a partnership with the Gulf Coast Consortia to develop a community-engaged healthcare educational program. So it's really been exciting to provide this educational opportunity where the community is educating our clinicians and our researchers in how to do this better, and how to develop and deploy, make available important life-saving interventions and technologies.
For me, it's all about watching the light bulb turn on, the fire get lit again or rekindled in our participants' eyes. And that's been the huge payoff for me, to see faculty come into being, become more excellent at what they're doing, to see the energy come back again, and it spills out into the students. They're happier people. It was just very rewarding.
CPRIT stands for Cancer Prevention Research Institute of Texas, and within the name itself, it is cancer prevention. So we applied for this funding mechanism under the prevention pillar of CPRIT, which positions us or allows us to be able to offer mammogram at no cost to uninsured and underinsured women. So with that, we are addressing a major barrier for that population. The fact that we're able to provide services that is a bit more convenient, accessible and specifically at no cost to uninsured, underinsured women is a big, it's a big priority for CPRIT, and we are very grateful to have been able to receive that.
One of the great things that are coming next in the future and that we're working on, because we like to think ahead and work ahead, is that the university has deployed a lot of infrastructure for artificial intelligence when it comes to artificial intelligence, the marriage between artificial intelligence and social determinants of health. So our core facilities here at Texas Southern University, we've deployed a lot of infrastructure, resources, and capacity into studying the role of artificial intelligence in addressing a lot of these disparities within maternal health and even using artificial intelligence for drug discovery and development. We hope that in the future, with all our work, we hope to see that the synergy of working together with the key stakeholders will really move the needle when it comes to reducing breast cancer health disparities within our community that we serve.
I remember this young lady, she had just gotten vaccinated. She's African American, and she goes home and she talks to her grandmother. Grandma, you need to be vaccinated. Grandma says, absolutely not. I don't trust the healthcare system. I don't trust any of these people. I'm not going to get vaccinated. The young lady says, well, Mom, the lady who vaccinated me is African American. She says, well, in that case, take me, I want to get vaccinated. The message is important, but so is the messenger.
Data and science and study have shown that African American individuals are much less likely to be enrolled into a clinical trial. So the EQB Med initiative is going to address this major and critical problem in our community.
EQB Med initiative positions us at Texas Southern University to actually have access to innovative and breakthrough clinical studies. We do a lot of work to increase awareness about clinical research participation, but without an opportunity to actually open access for individuals to participate and to build trust in clinical trial process, we are very limited.
Pharmacy is a very important team in communication with the community. And we are not only have a PharmD program, we also have a PhD program. With that, we have more outreach to the community.
We are the #1 producers of African American pharmacists in the state of Texas. Pharmacists are a significant part of the healthcare team. They're able to immunize patients. They're able to help them in a variety of health settings per se.
TSU had the RCMI support back in 1980s, especially in terms of research infrastructure. So the students and scientists can conduct most cutting edge of research, especially in the area of drug discovery and development.
In 2024, the College of Pharmacy and Health Sciences celebrated its existence of over 70 years. We lead a lot of initiatives advancing health equity, training community health workers, providing continuing education for community health workers as well as for our pharmacy and health administration students.
In this initiative, we are going to partner with UTMB, Yale University, and Morehouse School of Medicine. We will be able to gain more experience and resources and guidance on how to recruit for clinical trial and how to conduct clinical trials.
So this clinical research initiative under the EQB Med funding mechanism allows us not just to provide opportunities for clinical trial participation for community members, but it creates a platform for us to train the next generation of pharmacists that will be culturally competent, that will have an high level of awareness of engaging with community members to promote the concept of diversity and equal representation in clinical research participation. Hello, it is Veronica Ajowole here, Community Engagement Co-Director from Texas Southern University. I am very excited to inform you that we have our Maternal Child Health Conference coming up very soon, and you definitely want to be a part of this conference. During this conference, we'll be sharing a lot of information regarding the outcomes for maternal child health in our community, engaging with speakers and panelists that will empower us with knowledge and information to help us advance health equity in our community. Not only are we going to empower you with education, we will also be providing a lot of no-cost clinical services. Mammograms will be provided, no-cost immunization, women's health services, as well as a lot of vendor and exhibit tables will be available. So what are you doing? Go ahead and pre-register and join us either in person or online. I look forward to seeing you. Thank you very much.
Howdy, everybody. Welcome to our third annual Maternal and Child Health Education and Outreach Conference. My name is Cecilia Torres, and I'm an epidemiologist within CBMHR and the program coordinator for MHReach. And I'd like to welcome everybody here today in person, as well as our attendees online. The first thing I'll be doing is introducing our Master of Ceremony for today, Dr. Paige Johnson, who is a chiropractic physician with 8 years of experience in higher education. She is a United States Army veteran with 6 years of service to the country and holds a BA in psychology from Edward Waters College and a Doctor of Chiropractic degree from Palmer College of Chiropractic. She has taught biological sciences in the post-secondary education for the past 7 years. And when Dr. Johnson is not teaching, she is spending time with her 5 children and enjoying the various activities that Houston has to offer. Dr. Johnson is driven by a commitment to excellence and a passion for the biological sciences. She looks forward to contributing to the biomedical science program success here at Texas Southern University, and she is our MC for today's programming. Welcome, Dr. Johnson.
Thank you so much. I hope everybody is out there staying warm. But the work that is being done here in the community is so worth that. Okay, so I will be introducing Dr. Poon. Dr. Poon is a professor in the Pharmacy Practice and Administration Department in the College of Pharmacy and Health Sciences at Texas Southern University. Dr. Poon received her Doctor of Pharmacy from the University of Houston and a Master of Science in Palliative Care from the University of Maryland at Baltimore. She is a licensed pharmacist and a preceptor in the state of Texas and has served as a clinical pharmacy specialist and a preceptor for pharmacy students at the geriatrics clinic at the Michael E. DeBakey VA Medical Center in Houston, Texas for more than 20 years. Dr. Poon has served as a mentor for many junior faculty in research and professional growth, and her research interests are geriatric pharmacotherapy, palliative care, and pain management. Everyone give a warm welcome to Dr. Ivy Poon.
Thank you, Dr. Johnson. Welcome, everyone, for coming on this January cold day for this very, very important health condition or health disparity topics that we have. So we really appreciate you for coming in, and if you join online, we also appreciate you as well. Welcome to Texas Southern University CBMHR. So I'm going to spend the next few slides to talk about the agenda, and then also to talk about several housekeeping items. And so today we have a pack full of events, and we will have panel discussion, keynote presentations, and all the way from 10 a.m. to around 1:15 p.m. So A copy of the agenda is also should be in your packet, so you can always refer to your agenda in the folder for more information. And also in your packet, you will see several flyers of some of the upcoming programming that we have in CBMHR CEC. We want to say thank you to our sponsors and our partners and our vendors. There are so many that graciously lended hands to us, and then we work together to make this programming possible. So we want to thank you, everyone who contribute and make this program possible. Thank you. All right, so in your folder, you should have a notepad. If you have any questions, you can write down your question in a notepad. Once in a while, we will have these Q&A sessions where you can come up to the mic and ask questions. So if you have questions, write it down, and then wait for those sessions, times, moments where you can come up and ask questions. If you're joining online, you can also type your questions in the Q&A box, and then we will answer those accordingly as well. There are surveys that is available. Please complete the surveys. The surveys are voluntary, and it's not a must that you complete, but we encourage everyone to complete the surveys and to give us feedback on the programming. And also the surveys will ask questions about what do you want to hear more for next year, and also how it helps us to plan out the programming for the next coming years. Also, if you are joining to receive the 2 hours of CHW credit, make sure that you complete the CHW credit evaluation survey so that you can get your hours. Please stream live on Facebook, YouTube, and the codes are over there. You can text us to get connected, and this is our QR code with all the surveys and all the information that we have. Then I'll pass the mic back to Dr. Johnson. Thank you so much. Welcome.
I would like to introduce the First Lady who will be doing our opening prayer. First Lady Janice enjoys serving alongside her pastor husband at Fallbrook Church in Houston, Texas. Together, they have witnessed God grow Fallbrook Church from 5 families to over 10,000 members. She serves as a ministry leader, a Bible teacher, and a conference speaker to women. She has mentored and counseled hundreds of women in various life stages and developed programs encouraging their success. Her passion leads women to ignite with hope through a deeper relationship with God. First Lady Janice received a bachelor's degree from the University of Houston, downtown, a master's degree in professional writing from Liberty University, and is working towards an EDD in leadership at Trevecca Nazarene University. Please help me welcome First Lady Janice Pender.
Thank you. Thank you. God bless. I'm just so privileged to be here in the midst of this wonderful event, and just an honor to open up the event in prayer. So thank you for the invitation to all of the TSU team and leaders. I appreciate that. May we bow in prayer. Heavenly Father, as we gather today at the 3rd Annual Maternal and Child Health Education and Outreach Conference, Lord, we are reminded of 2 passages in your word. Let each of us look not only to our own interests, but also to the interests of others. And Lord God, we also are reminded to not let us grow weary of doing good, for in due season we will reap if we do not give up. Lord God, we thank you for this opportunity to come together to share knowledge and to learn from one another. Father, we thank you for the diverse group of attendees that are in person and online. We are also grateful for the vast array of experiences represented here today. May we learn from each other and collaborate effectively. Lord, we ask for the Holy Spirit to guide our conversations and illuminate our paths as we seek truth together. Father, we know that you have a divine agenda, and we want your will to be accomplished through this important event. May our hearts be open to new perspectives, our minds be sharp in understanding, and our actions be motivated by a desire to serve our community. Bless the gathering with your presence, Father, and may the outcomes of this conference bring positive changes. We pray this in Jesus' name, amen.
Next, we'll be introducing a wonderful and amazing person on this campus who is not only a motivator, but she has a contagious smile and warmth about her as you see her here on campus. Dr. Michelle Penn-Marshall is the inaugural Vice President of Research and Innovation at Texas Southern University. DRI was established in March 2022 and is since its inception, research expenditures have increased by 32.8%, funding requests by 90%, and funding received by 80%. Dr. Penn-Marshall received the BA Scientific Curriculum and MS in Biology with a concentration in Environmental Science from Hampton University. She received her PhD in Community Nutrition from the Department of Human Nutrition, Foods, and Exercise at Virginia Tech. Dr. Penn-Marshall is the PI for the U.S. Department of Education Research and Development Infrastructure, entitled Path to R1 at Texas Southern University, which is $4.99 million. She is also leading the Catalyst for Urban Transformation, a $40 million project that will create a research and innovation nexus for faculty, students, and community members to address urban Americans' grave challenges. Please give a round of applause for Dr. Michelle Penn-Marshall.
Thank you, Dr. Johnson. I'm just so honored to be here, and if I start calling names, I will make mistakes and leave someone out, but the reason that you can even see some of the numbers on that screen would be because of many of the people who are in this room and the faculty that are not present or maybe online, as well as the students. So I want to take a moment just to thank them for their hard work, for their passion, and for their motivation, and a lot of it is led by this lady right here. So can we just give them a round of applause? Thank you. Thank you. Now I'm going to do what I was asked to do. And I want to thank First Lady Pender. You really covered it all. Between you, God, the scriptures, and the Holy Spirit, you covered it all. We cannot leave here without measurable outcomes, and we have a charge and an action for change. So thank you for being his willing vessel. We know that God, we can do all things through God who strengthens us. We know that also all things are possible if only we believe. Don't be moved by all of the news that you see and the things that you see. I got inundated with it and got a little bit off track yesterday, completely off track, almost woozy. But I told the team that I was talking to, the president was on the call, and I said, you know what, I am completely distracted. And once I said that, I was able to engage, get my bearings, and God helped me speak and say what needed to be said so that we could move forward with a strategic plan for this university. So please note, we all swerve just a bit, but let's come back in, keep our eyes up, and remember what's important and take care of each other. So on behalf of President James W. Crawford, the administrators, the faculty, and students, it is with great pleasure that I welcome everyone in person and everyone who is online to Texas Southern University's 3rd annual Maternal and Child Health Education and Outreach. We are an urban university transforming the lives of others while we also transform our own and our students. We are here today and gathered as a community of professionals, advocates, and supporters. We are united by our shared commitment to improving the health and wellness being of mothers, children, and families. Dr. O often tells us this is structural racism, and she doesn't just say that and then not do something about it. She works with teams. They work together to stay up late, to bring a coalition together so that we can effect change. We have a responsibility, and it's honestly a privilege to do so. I want you to understand that at Texas Southern, we are deeply committed to advancing maternal and child health. And you can't just be committed in words. We have to be committed with our finances. We have to be committed with our tools. And some people don't mind asking, hey, can you pay for that? And I'm like, okay, let's cobble it together. And I'm down in the CFO's office knocking, and he's looking at me like, are you really asking me for this? And I just keep coming back until I get a yes. So that's what we do. That's what we do because, and he knows how important it is, but he has a fiscal responsibility, and I have a different responsibility. So we work together to get it done. I need you to understand that Texas Southern stands firmly behind the goal of ensuring that all mothers and children, regardless of background or circumstance, have access to care, support, and resources that are needed to thrive. We live in the largest medical center in the world, in the nation, and there are just no excuses for us not to lead the way in this regard and others. We recognize that the path to better maternal and child health is not one we can walk alone. So it does require collaboration, innovation, and sustained effort from all sectors, healthcare providers, our commissioners, our policymakers, our community leaders, and organizations like each of you represent. And as we work together, I pledge to continue strengthening our commitment as an institution to this cause by fostering interdisciplinary research, supporting community outreach programs, and advocating for policies that promote equitable health outcomes for all families, all people. And I do believe that through this collective action, we can make significant strides toward a future where every mother and every child, just take a moment to reflect on mothers and children that you see in the stores sometimes, that you see on the streets sometimes. I'm from a rural county in Surrey, so in Virginia. I'm not used to seeing people with their children with flowers outside trying to sell the flowers. So just keep those things in mind, and let's do what we can to effect the change so that everyone can live a healthy, fulfilling life. I want to thank you in advance for being a part of this important conversation, and we look forward to the dialogue, partnerships, and actions. And you'll see me coming in and out. I have other meetings, but this is so important to me. But I'll be back. And actions that will emerge from today's event. So welcome, and let's get this done. Let's make a change. Dr. Johnson. Thank you. Thank you.
Next, we have Dr. Ajawale Mwemwa, and she is one of the juggernauts here in research. She is a major contributor to the community, its education, its outreach, and just talking to her, you know she cares, it's in her spirit. She's amazing. Dr. Ajawale Mwemwa serves as a professor at TSU and as a clinical pharmacist and an adjunct assistant professor of oncology at Houston Methodist Hospital. She received her PharmD from TSU and completed her oncology pharmacy residency at Houston Methodist Hospital. She is a board-certified oncology pharmacist with clinical practice in oral chemotherapy, Houston Methodist Hospital Cancer Center. She is the founding director of the NIH-MD-funded Community Engagement Core of TSU's Center for Biomedical and Minority Health Research and TSU's Institute for Health Equity Advancement Research and Training. Dr. Ajawale Mwemwa is the program director for TSU's Breast Cancer Screening and Prevention Center and the host for this conference. We are excited to have her present health equity programs at Texas Southern University. Please give a thunderous applause for Dr. Ajawale Mwemwa.
Thank you very much. Good morning, everyone.
It is such a pleasure to be here, and that thunderous applause belongs to God and to God only, and to Him be all the praise. I am super excited to be here this morning. Thank you all for joining us in person, defying the cold. I stepped out of my car, I'm like, oh my God, it is freezing. But you know what? You guys shook it off for a good reason, right? Like, oh yeah. Despite the snow, I call it Houston Snow Day, right? Some call it different names, but for me, it was Houston Snow Day. The kids had fun. I hope you all enjoy the weather and, staying safe and warm. But it is such a pleasure to be here with you all this morning. I am very privileged, to have the opportunity to convene this conference again, being the third of its kind. And, this time around, we are going to do a little bit, different things if you've been following us for some time. But it's really packed with a lot of great information. But my duty this morning is to share a little bit more information regarding the Center for Biomedical and Minority Health Research, as well as the breast cancer program. So I am very excited. In 2020, we received funding from NIMHD, $8.6 million award under the leadership of Dr. Monica Olaleye. Please help me to appreciate my mentor, and I call her the catalyst. Alongside Dr. J, Dr. Liang, to be able to implement, this community engagement core, working alongside Dr. Gao as well as Dr. Poon. Dr. Poon, amazing support, silent and quiet giant. We are just very grateful for you. So within the community engagement core, we have three major responsibilities. And I am beyond grateful to have had the opportunity to fulfill this over the past 4 years and even into the future as God continues to lead us. First thing is for us to be able to identify and address health disparity in our community. So if you see us busy, right? We are doing something every single month. We are very engaged in the community. It is because this was the cause, this was the promise that we made to the government, and now we have the funding. We have had the opportunity to do so over the past 4 years and again into the future as God continues to lead us. The second aim is for us to increase clinical research participation. Everything, no matter what disease state, maternal, cancer, hypertension, what have you, there is an interlink with clinical research participation. So Community Engagement Core is doing a lot of work in that regard. As a matter of fact, we have a table outside, dedicated towards clinical research information. So if you want to learn more, you have an opportunity to do so. And then the third thing is for us to gather around in conferences, outreach events of this nature to be able to share information out to the community. And we do this, as smart as we can, leveraging technology. We just don't gather physically. We also have a lot of people online, people on Zoom. Hello. YouTube, Facebook, Twitter, X, wherever you are. We appreciate you all for joining us this morning. Again, part of the work that we do in the Community Engagement Core is for us to host this type of events. And not only that, we listen to the feedback from the community. So please complete the survey. There is a QR code on the booklet in your packet. Use that to complete the survey, or if you prefer to use the paper survey, that is also available, because we are very intentional in being attentive to the voices of the community and ensuring that is reflective in what we do. Again, very intentional in building trust. We hold focus group sessions as well as a lot of opportunities to hear back from the community. Let's see. Over the past 4 years, again, this slide is showing us some of the activities that we've been able to do. Community Engagement Core being established for the very first time, 2020, we've been able to support 69 different research grant funding over this past 4 years. We've been able to engage, having interaction on social media, supporting the Research and Innovation Week, a lot of attendance, over 1,000 people attending our conferences on clinical research and engagement, as well as a lot of activities in different and diverse aspects within our community. I will switch gears here a little bit and talk about the breast cancer and screening program. I'm looking at my time because the clock is off.
Thank you for working on that. Thank you so much. I don't want to take more time on the stage than I need to. So I also have the privilege of leading a $1 million award received from CPRIT, where we've been able to provide mammogram at no cost to uninsured and underinsured women. And to God's glory, we have screened over 1,400 women in 5 counties within these past 3 years. So again, when you talk of, doing the work, we just don't receive the money. We receive the money, and you can see the impact of the work that is being done. So again, very, very grateful. And as we speak right now, 27 women are out on the Tiger Walk on the mobile units receiving mammogram at no cost today. So again, very grateful to be able to do this work. Then another really exciting one, whenever I get to this slide, I get super excited. I want to jump out of my skin and say, yay, our mobile unit, very much long awaited, will be here in a couple of weeks, and very excited to be able to do this. Thank you, Dr. Lale. Thank you so much, VP Penn Marshall, for your support and your leadership, to be able to acquire this mobile unit. And now we will be deploying these mobile units on our streets in Houston and all around within the next few months. So very, very grateful to be able to do this. One of the other initiatives that we are very excited to be able to lead is the EQB Med initiative, where we are now leading the charge of implementing clinical research here on Texas Southern University campus. This is an initiative that we would not have been able to do without the visionary leadership of Dr. Lale and, of course, VP Penn Marshall. Oh, my God. We came in and we told, okay, VP, how can we, when you look at the concept of innovation means you are bringing ideas to the table that sometimes disrupts your structure. But there is no time that I pick up the phone and I say, VP, we need this. VP will say, okay, Veronica, let me see how I can help. And I am beyond grateful to you for your support and your leadership. Thank you very, very much. Once again, we have our table out there where you can engage with us. We have our clinical research coordinator if you want to learn a little bit more regarding our clinical research and engagement information. We have the privilege to lead several initiatives. We've kind of encapsulated everything under IAT, because that's really what everything is leading towards. So the Institute for Health Equity Advancement, Research, and Training, and with this doing, grants and research, looking at diversity in the workforce, access to healthcare, and we are open to donation and sponsorship, okay? So, I also have a software of asking for the money. Bring me the dollars, okay? I just don't write grants. We are also very much open to donation and sponsorship. And you know what? Today's event would not have been successful without the faces of everyone that you see on this screen. Please give a round of applause to this amazing dream team here at Texas Southern University. I am beyond grateful, beyond excited to work alongside each and every one of this group of individuals. But besides that, there is a face that you wouldn't see, but he is sitting right here. Please permit me to appreciate and thank my lovely husband. Thank you so much. We've been married for 12 years and forever to come, right? Just very grateful for your support and your love. And while I do have my own personal maternal child health story, this man stood by me at every code blue that I had in the process of having my own children. Not once, not twice, not 3 times. So I'm very grateful to you. You could have turned around and I'm like, wait, what is wrong with this girl? But when God gives you a reason to have a second chance, you grab that life and you're like, man, I don't want other women to go through what I went through. So I'm very grateful to you and to each of you that have joined us today. Thank you so much for joining us this morning. Again, you defy the cold weather. And I'm going to end by asking you, why exactly are we here today? We are here to fellowship, to say hi to each other, but most importantly, to learn. Right? So please, the rest of this afternoon, or the rest of this morning leading into the afternoon is packed with a lot of great information. We have amazing panelists, group of experts from all around, speakers flying in from out of state to be able to share information with us today. So please, I applaud you to please listen learn, and most importantly, make a decision to lead something. Let us not be the group of people that will just complain and talk about it, but there is something you can do within your community, within your own cycle of influence to advance health equity for mothers and babies. So welcome, and I look forward to an amazing event today. Thank you for joining us.
I'd like now to introduce our keynote speaker, Nicole Lee Plenty, Dr. Nicole Lee Plenty. Growing tired of seeing complications in pregnancy that could have been prevented, Dr. Plenty wanted a way to help women empower themselves through knowledge so that they can advocate for themselves. The quest to educate women birthed the podcast, Pregnancy Pearls with Dr. Plenty. Dr. Nicole Lee Plenty is a double board certified OBGYN and maternal fetal medicine specialist, blogger, public speaker, and patient advocate. She graduated from Xavier University with a Bachelor of Science in Biology with honors, then obtained a dual medical doctorate degree and a Master of Public Health from Tulane University. Dr. Plenty completed her OBGYN residency training as well as maternal fetal medicine fellowship at the University of Mississippi Medical Center, where she also earned a Master of Science degree concomitantly. Nicole has served as a state and national leader in various sections of the American Medical Association and American College of Obstetricians and Gynecologists. Please give a warm welcome for Dr. Nicole Lee Plenty.
Thank you guys for having me. Good morning. So I am one of those people that flew in. I used to practice medicine full-time here in Houston, Texas, covering about 17 different hospitals in this area, providing maternal consultations. But now I am the founding director of Maternal Fetal Medicine Division at Wellstar Health System in Atlanta, Georgia. So it's good to be back home. All my family is still here in Houston, so it's always good to be back home. So today we're going to talk about improving maternal and child health in the African American community. And I honestly want this to be a discussion, although you gave me 20 minutes, so we're going to keep it quick. So they've already introduced me. Thank you for that amazing introduction. I do have to give some disclosures. I'm actually glad I have financial disclosures, y'all. Like, usually we don't have those kind of things. So, of course, this is not done on behalf of Wellstar, who is my main employer. I am a medical advisor for Billion to One, which is a prenatal genetics testing company, and also a former board of directors member for the American College of OBGYNs, as well as a leader for the American Medical Association. So the reason I started Pregnancy Pearls and Pregnancy Pearls podcast and the blog is because of this. I had a cousin that was 23 years old. She was pregnant with her second child. She was a college graduate. She was married. She was a former cheerleader. She was thin. She was healthy. She had no medical problems at all. But one day she had a headache. And because of that, she took Tylenol, it didn't go away. She called her doctor. Her doctor said, "Oh, you'll be fine. It'll be fine." Her mother found her down the next morning in the kitchen. They called EMS and rushed her to the hospital. Our small little community hospital, I'm from DeRidder, which is like 11,000 people in Louisiana. You know what, that's okay. They then flew her to New Orleans, to the hospital there. After flying her there, they transported her to Baton Rouge's General Hospital. She passed away about 2 weeks later from complications of acute respiratory distress syndrome, preeclampsia, which developed into an eclamptic seizure, and then ultimately lung and cardiac failure. I was in college at this time, and at that time I was pre-law, and I became very nosy. I said, that should not happen to somebody that's young and healthy. I started doing research on preeclampsia, finding out more information, changed my major to pre-med, and then went into OBGYN and ultimately maternal fetal medicine. When I had my child, who's now 5 years old, I realized that, man, I have a lot of connections. I can pick up the phone and call people and say, this is what's wrong with me. At 10 weeks pregnant, I developed a massive blood clot in my leg. I had 5 pulmonary emboli in my lung, which are blood clots in my lung. I had heart failure and heart strain. But I picked the phone up and I called my OBGYN. Even before I knew what was going on, I said, listen, girl, I have a DVT. I'm going to the ER. I need you to go ahead and do lower extremity Dopplers on me. She's like, are you sure? I said, I'm sure. And I did. And I talked to the cardiologist, who was a personal friend of mine. I told them what to start on me. I talked to the hematologist and told the hematologist, this is what you need to start. Even though they said, well, we can start you on a Extra. I'm like, that's not pregnancy safe, so you can't start that. And then I realized if this can happen to me, it really can happen to any of us, right? Except for I have the connections, and this is my field, and I can call up my friend who's a pulmonologist, or my friend who's a cardiologist, or my best friend who delivered me, who's my OBGYN, and say, this is what I need done. And so I realized that everyone doesn't have that connection. And so that's why I created Pregnancy Pearls, that gives free information to patients so that they know how to advocate for themselves and what questions to ask. And this story is not just for people like us, right? Famous people die too. Educated people die and have complications. Dr. Shanice Wallace is a pediatrician in Indiana, and she obviously is educated. She had her child. She then hemorrhaged and had brain herniation. She had people that did not listen to her complaints, and she died. Then you have, of course, Olympic star Tori Bowie, who passed away from complications of high blood pressure. And then we all know Doug Hatchett's daughter-in-law, who passed away from internal hemorrhage because she was ignored. They took her back, and by the time they got there, she was in shock. It was too late. Now we have to deal with this, especially in Texas, where we have abortion restrictions here, and women are dying. So this is not a pro-choice, pro-life issue, okay? This is a safety issue that we need to advocate for these patients and make sure they have access they need, the education and resources they need so that they can not avoid the hospital when they have complications of crossing state lines to get terminations. So why are we dying in pregnancy, right? The numbers keep telling us it's getting worse. Mental health conditions are number one cause of maternal mortality, followed by hemorrhage, heart disease, and hypertensive disorders. But when we look at people that are black and brown, it's heart disease and hypertensive disorders. So this is data from Texas, 2013. You can see that the rate of maternal mortality in non-Hispanic black women is twice that of Caucasian women. And then we fast forward to looking at severe maternal morbidity. We can now say in 2020, we're now 3 to 4 times when we talk about severe maternal morbidity compared to Caucasian women. So overall maternal death rate is 22.3 per 100,000 live births as of 2022, and that's all encompassing, all races. Black maternal death rate is 49.5 per 100,000 live births. Behind that, Caucasian women, 19. Hispanic women, 16.9, and Asians, 13.2. So you can see we are triple that of other ethnicities. First, people wanted to blame it on COVID, and so I put this slide in because it's not COVID, y'all. Because people are like, well, you know, black and brown women had more COVID. There are more people in the household. COVID spreads more. We're more social, so people don't know how to social distance. You know, it's not COVID, okay? So if we look at the numbers, right, look at the numbers of COVID. Look at the COVID column. If we have the bottom is our non-Hispanic Caucasian rate. The red is the non-Hispanic black rate. Hispanic is the big blue rate in the middle. And then the yellow is everybody else. So you can tell if you look across all deliveries, all severe maternal morbidity, all the COVID-19 cases, and combined, We do not have the highest numbers, right? We're far from it. Hispanic women way outnumber when we talk about COVID and morbidity and mortality. Yet, our rates are still higher in terms of dying. And we can't quite figure that out. So our latest MMRC data here in Texas, 44% of the reviewed pregnancy-associated deaths from 2019 were pregnancy-related, okay? Meaning they were caused by something that happened in the pregnancy, not they were pregnant and got in a car wreck. So I just want to make sure we're differentiating that data. Violent pregnancy-related deaths with a manner of death or suicide or homicide represented 27% of pregnancy-related deaths. So we have got to circle back around to violence and mental health at some point because that's a big deal. And the leading causes of pregnancy-related deaths, hemorrhage, mental health condition, non-cerebral hemorrhage, injury, and then cardiovascular conditions. The biggest thing is 90% of pregnancy-related deaths are considered preventable. So we look at Harris County specifically, because usually people blame it on access to care and things like that. Harris County is not a maternity care desert. There's like the biggest medical center in the nation here, okay, in the world. Only 60% of pregnant patients in Fort Bend and Harris County receive early prenatal care. That's a big deal, right? We have got to get people in care sooner, and we have got to get people in preconception counseling and management sooner before they get pregnant. Texas is ranked last in the country for early prenatal care, and 1 in 20 pregnant patients in Harris County do not receive any prenatal care. So since we couldn't figure out why, it wasn't COVID, it was not access, because we see that they have access. Is racism a factor in medicine, right? Nobody really wants to talk about that. You bring that up in hospital committees and they're like, why is race always on the table? I'm like, because Black women are dying and nobody could tell us why. So this group is dying more than any other group, and so we have to talk about it. So we looked at this study. This study is from the American Heart Association. They looked at 4,000 Black women in Boston that were born in and out of the U.S. We found that people that were non-U.S. born, when they had their babies, they had less maternal morbidity and mortality, almost that of Caucasian women. However, once they were here for more than 10 years, their mortality rate increased, okay? It was that of Black women. So some of this systemic racism, this implicit bias that people are experiencing, chronic stress that Black women have to do, we have to realize that that has a lot to do with it. And until society changes how they treat women, how they treat Black women, the microaggressions we have to deal with, we're going to continue to deal with chronic stress. So we have to do things to mitigate racism, particularly racism in medicine, but honestly, racism in society, so that we don't have to endure chronic stress that then ages us and puts us more at risk for hypertensive and heart diseases. So what can you do? Okay, people always say, well, we're talking about what can we do? We can host events like this, right? So we can talk about it, get the word out, advocate for someone that you know is pregnant, go to people's visits with them, ask questions. It's our job as doctors to answer questions, right? So a doctor that's trying to brush a patient off, find a new doctor. You can find a new one, advocate for yourself, and move on. Of course, you want to disseminate information, barbershops, hair salons, churches, daycares. This is where we know we're at, right? We are at the church, okay? We're there every Sunday, paying tithes. We are there, okay? We're getting our hair done. We're going to look good. So let's get that information to those places that we know we're going to spend money in, okay? We're going to partner with health departments for resources, work with community leaders to provide blood pressure screenings, and if people have hypertension, show them where to get care and encourage them to do so. Encourage your age-appropriate screenings and wellness. I cannot push this more, that if you are healthy before the pregnancy, it's safer to get through the pregnancy. Of course, there are exceptions. I was an exception, right? But in general, starting your foundation healthy means you're going to go through healthy. And some of this is just your age-related screening, okay? How many people in here are over 40? Okay, if you are over 40 and you have gotten a mammogram in the last year, raise your hand. Okay, y'all doing good in here. But there are a lot of people that don't do those things, right? 45, you should have your colonoscopy. You should start your colonoscopy screening. 40, lipid screening, cholesterol screening, screen for thyroid disease. Like these things that we have to do these things because those are the things that lead to things like heart attacks later on, okay, in or out of pregnancy. And then once you're pregnant, doulas. I think that every pregnant woman, especially if you're high risk, should have a doula. And I don't know why. There's a lot of doctors that don't like doulas, y'all. I don't know why. I have no idea why. I'm like, are you threatened? Do you think somebody's going to take your job? I have no idea why. But especially if you are in a high-risk environment, meaning you have a high-risk condition, you don't have a big family support around you, you may be a single parent or going through the pregnancy by yourself, you don't have anybody to go to the visits with you, you really do need to think about getting a doula, okay? And a lot of hospital systems will allow you to have one for free. They'll provide you with a doula now. So especially reach out to your health departments in your area if you don't know where to start, because a lot of health departments do have doula programs there. So if we look at the maternity rate for Black babies, we see that it's cut drastically if they're cared for by another Black physician. Like they have like a third less mortality if they're cared for by a Black physician, okay? That tells us we need to do something more in education, okay? We need to have more TSU students going to med school, okay? And an HBCU is the way to get there. I'm a graduate of HBCU. When I saw it, I was like, she said Xavier University. It's really Xavier University of Louisiana is where I went, okay? And the other HBCU in Louisiana. But, you know, HBCUs are really a good avenue to get into med schools and then residency. Doctors that look like me, a lot of us have gone to HBCUs, okay? So we do need more people going into medical school and becoming doctors. The preconception screening, I cannot stress this enough. Get a preconception screen, okay? Our health department, our community advocates, our community workers, if you are seeing somebody that's of childbearing age, encourage them. Hey, have you talked to your OBGYN about what your plan is for pregnancy? That retinoic acid that you're using is not safe, okay? I know it helps with your acne, but it is not good. And there are things that we use every day that we should not be using in pregnancy. Those are things that can cause complications later on. So we need to make sure our health is in tip-top shape and that we're doing things that are preparing our bodies for pregnancy. So we want to make sure you're getting your cervical cancer screening, meaning your pap smear. If you're 21, you should have started your pap smear. If you have a family history of certain cancers, you should be screened even earlier than the recommended time. Breast cancer. Black women are more likely to have triple negative breast cancer, and they are diagnosed late, okay? And that's because sometimes we're not familiarizing ourselves with our breasts. We're not talking to our families about our histories. We're not saying, well, what did Aunt Susie die from? What did Big Mama die from? What are these people that when I was little, what did they die from? Find out about what is going on with your family so you know when you should start your screenings, okay? For screening, mammogram is safe during pregnancy. So let's say you got pregnant, you're 40. You can still get a mammogram during pregnancy, and you should continue to get your mammograms annually. Breast ultrasound, of course, those are supplements for younger people that are younger because we have more, they're denser breast tissue in people that are younger. So most people get a digital mammogram or a breast ultrasound in conjunction with that. And of course, you're going to start at 40 or earlier depending on your family history. Blood pressure and diabetes screening. I don't know how many patients I have seen. I don't know why. It's like people are younger with hypertension now. Some of it is owing to obesity. Some of it may be owing to high cholesterol. Some of it is owing to just a family history of high blood pressure and a chronic stress environment, okay? So we do need to, blood pressure, diabetes screening, okay? If you are younger, you're in college and you have high blood pressure, that is not normal, okay? It's not. I mean, high blood pressure is not normal. And if your pediatrician says, it'll be fine, we'll come back and see you in 6 months. No. what are we going to do about this? This is not normal. Okay, you need to advocate for yourself. Your blood pressure should be normal, okay? Normal. And if you have a doctor that's trying to start you on medicines, listen, I know we don't want to start medicines. We don't like to start medicines, okay? I'm gonna walk. I'm gonna eat low sodium. Listen, just take the medicine. Once you're controlled, get off the medicine, okay? If your goal is to lose weight, that's fine. Give yourself a timeline to lose that weight. If you haven't lost the weight in 6 months, it's time to get on some medicine, okay? I'm being serious. I have to argue with people all the time about them not wanting to take antihypertensives in pregnancy, knowing that it will prevent some downstream consequences later on. Okay, so I have to touch on breast cancer a little bit because it's a pet peeve of mine because black and brown women don't like mammograms, okay? We have got to become familiar with our breasts. We have got to get our mammograms, okay? Now, at TSU, y'all have mobile mammograms now? There's no excuse. It's free. Get your mammograms because we know that when we look at this younger population, ages 20 to 49 in the U.S., breast cancer is leading the way. And so we're talking about outside of pregnancy. And with us, we have later diagnoses. The later we are when we diagnose this, the harder it is to be completely cured. And we want you to be around here for 5 years, okay? At every age, black women are more likely to die from breast cancer than any other age group. So I just want to stress, make sure you get your screening. Make sure you're up to date on your preconception care. If you're a community worker, encourage somebody to get their regular exams. Find a primary care doctor. Find an OBGYN. They are out there, and you can choose them that look like you. Go online and find who you like. And if you get there and you don't like them, you can always switch and choose somebody else. Does anybody have any questions for me? Yes. Oh, one question, she says. Any questions? Because that's not true, right? Because once your blood pressure is controlled, you can get off of it, right? So there's a lot of people that lose weight. And now all of a sudden they don't have to be on insulin anymore. They don't have to be on the metformin anymore. They don't have to take the lisinopril anymore for your blood pressure. So if you're controlled, and you'll know when you start to become controlled. Like once your eating habits change and you start to lose weight, and then all of a sudden you're like, I check my blood pressure in the morning, it's like 130/80. I'm like, hold that, hold your medicine. Obviously don't bottom yourself and take your medicine, then you're falling out on the kitchen floor. But hold it. If you're holding it for multiple days, then you talk to your provider and say, hey, my blood pressure is normal without this medicine, or my diabetes is completely normal without this medicine. And most of the time, we'll take you off of it. So it's not like you have to be on it for the rest of your life. If you control with diet, exercise, and then weight loss modification, then you may not need to be on it.
Yes, but I'm just saying, I was told this 20 years ago.
Yeah.
I'm 62. So just think, if they're still saying that now.
Yeah.
That
may be the resistance.
That might be the resistance.
Yeah.
Somebody tell you that you're going to have to be on that for the rest of your life.
Yeah.
They kind of play it back and forth.
Yeah.
Sometimes that's the fear factor, you don't know. And then it's a conversation of not being assertive to ask, inquire like you're saying.
Yeah. One more? What? Okay. Real quick? Okay. Thank you, guys.
Thank you so much. Thank you so much, Dr. Plenty, for that. Now I'm going to introduce our panelists. Ms. Ramatu Mansare, did I say that right? Is the Deputy Assistant Director / Director of Nursing at the Houston Health Department. She is an experienced and accomplished public health nurse with practical, clinical, and leadership experience in women's health. She currently has a Postmaster of Science degree in Nursing Education from the University of Texas Health Science Center a Master's of Science in Nursing from the University of Texas, a Bachelor of Science in Clinical Laboratory Science from the UTMB, and a Bachelor of Science in Biology and Chemistry from Sam Houston State University. Currently, Ms. Mansoray is serving as the Maternal and Child Health Lead for the Houston Health Department. She has a personal and professional goal of working towards ensuring the health and well-being of both the mother and the baby regardless.
Thank you. Awesome. Good morning, everyone. And thank you for having me here. Thanks for the introduction. I will briefly go over some of the programs that we have at the Houston Health Department. Awesome. Excellent. So the Houston Health Department really functions as a safety net for a lot of the programs in trying to work with community partners to try to address several things. Today, our focus, of course, is maternal child health here. So some of our key programs are our WIC programs, Nurse Family Partnership, as well as Healthy Families Houston, and we have our Family and Reproductive Health program, which is in our health centers. And then, of course, we have some other internal programs that work with mothers and babies, including that is our perinatal hepatitis B program, as well as adolescent health and violent prevention, and our C to Succeed that works with providing eyeglasses to kiddos, our dental services, which is also with our Project Saving Smiles. And of course, we have our lead and asthma programs, which goes out in the community working with lead abatement in the homes for some of the clients within the city of Houston, as well as our asthma programs working in the homes, and then also at the schools with the students there as well. Just some numbers there for those that like numbers. Our WIC program on a monthly basis serves over 61,000 clients. Our family planning encounters annually are over about 36,000. And our nurse family partnership programs, they see about and support about 150 families annually. I'm going to briefly focus on two of our programs really quickly here for you, and that is our Healthy Families program, Healthy Families Houston. They focus on our teenage clients between 14 and 19, with the goal really to reduce the risk of child abuse, and then, of course, improve maternal and infant mortality rates. And this is done through educational programs and interactions, and also with service linkage. It is often very challenging to talk to someone about preventing child abuse if they themselves are in a challenging situation, if they're having to address food insecurities, if they're having to address challenges with their housing and different things like that, or if they're having to address mental health issues. And so really trying to work with them to address some of those. As I mentioned, this program is for first-time teenage mothers between 14 and 19. They must live in Houston, and this particular program is accepting clients. There's the contact information, and of course, you can always reach out to me. My contact information is at the end. Another program we wanted to highlight for you guys was our Nurse Family Partnership Program. This is another accredited program that we have in Houston. This is where we have registered nurses paired with clients during pregnancy up until the baby's 2 years of age. And these nurses have a clinical component as well as some care coordination components. And so they will be working with the clients to monitor their progress from pregnancy onward and providing that support where they're needed. If, they're having challenges with their blood pressure, if they're having challenges with diabetes and things like that during their pregnancy. They also work with them to help identify developmental changes in their children. Once the baby is here, are the babies meeting developmental standards? When do I need to take my baby in?
what is the question? And I'm also teaching them how to look at some of those cues that the children have to be able to address and support them. There's a point of contact there for them, and you can always, of course, reach out to me if you have any questions. That's me. All right. Thank you.
Thank you so much. Next, we have Ms. Cassie Sue. Cassie Sue is the Maternal and Child Health Assistant Program Manager at Harris County Public Health and a dual MHA/MBA candidate at the University of Houston Clear Lake. Cassie's commitment to maternal and child health began after receiving her Bachelor of Science in Neuroscience degree from Baylor University, where she was offered a research internship at the University of Kansas School of Medicine to investigate discrepancies in breastfeeding rates among rural and refugee communities. Her research developed virtual breastfeeding support groups to improve access to maternal health care resources. Ladies and gentlemen, Ms. Cassie Sue.
Good morning, everyone. My name is Cassie Sue, and I work with the Harris County Public Health Maternal and Child Program under our Community Health and Wellness Division. It's a pleasure to be here. Today, I'll be providing a brief overview of Harris County Public Health's maternal and child health programs and initiatives. Harris County leaders came together to adopt a public health approach to combat maternal and infant mortality within Harris County, a call to action in response to the alarming statistics. HCPH promotes programs and services designed to reach mothers, birthing persons, and families who face significant barriers to care and are often underserved. Our mission is to meet individuals where they are and create sustainable pathways to accessible, equitable, and consistent maternal health care. Our maternal and child health program was established to reduce maternal and infant mortality risks and empower expectant mothers and birthing persons to create a foundation for a healthy family. The program also includes a maternal mental health program, which provides mental health therapy and support services to birthing persons, as well as a full-time lactation consultant who provides in-home lactation consultation and support. Many of us are familiar with WIC, Women, Infants, and Children, a federally funded public health nutrition program serving pregnant women, breastfeeding or postpartum individuals, infants, and children up to age 5. Access Harris County, standing for Accessing Coordinated Care and Empowering Self-Sufficiency, is an integrated care coordination model aimed at improving outcomes for vulnerable populations through a holistic care coordination team. Access houses our Black maternal health cohort, providing wraparound services to Black or African American birthing persons who often face the disparity of being 3 to 4 times more likely to die during childbirth than their counterparts. And most recently, we were awarded the Healthy Start Grant. This program aims to improve outcomes for women, infant, and families before, during, and after pregnancy in 14 specific zip codes within Harris County. Collectively, our internal programs alongside our Maternal Health Bill of Rights initiative, we are optimizing our ability to positively impact the communities we serve in Harris County. Specifically, the program I have the privilege of managing, which I'll be diving into more detail today, is the Maternal and Child Health Program. We have implemented evidence-based strategies, which include home visiting support. Our community health coordinators provide in-home one-on-one support for up to 3 years. This fosters healthy births, positive family growth, and self-sufficiency for our participants. We address the needs of the entire household, including children, partners, grandparents, and other caregivers, because we understand that it takes a village and we're here to support every part of it. Additionally, we recognize the importance of emotional well-being during and after pregnancy. Through our Growing Great Kids curriculum, we offer personalized home visit support to help navigate the nuances and challenges of motherhood, foster healthy parent-child bonds, and equip families with the tools for thriving relationships throughout the household and beyond. Resources and education include counseling, substance use disorder services, job placement support, food assistance, and educational advancement. We recognize that our curriculum can only be effectively utilized if we are also addressing the complex and unique needs of our participants first. The Maternal Health Bill of Rights outlines the rights of birthing persons and families. promoting respectful, equitable, and high-quality care before, during, and after pregnancy. It serves as a roadmap for healthcare providers and healthcare systems to promote transparency and communication of the rights of birthing persons and their newborns. Tomorrow, we are hosting our Maternal Health Bill of Rights 5K walk run at McGregor Park. And on April 15th and 16th, we are hosting our 3rd annual Maternal and Child Health Conference. And we would love to see you all there. Please visit our table outside for more information. Oh, additionally, in order to be a part of our program, we only ask that you meet 2 criteria: that you're a Harris County resident, and that you're currently pregnant, delivered a baby within the last 12 months, or experienced a pregnancy in the last 12 months. Lastly, to go over our evidence-based practices and curriculum, Healthy Families America equips our staff with the essential training to deliver home visiting services tailored to family needs, dependent on the family's level of sufficiency. And Growing Great Curriculum provides prenatal to age 3 education to new and existing birthing persons. If you look at the visual on the bottom right, it illustrates how our program promotes maternal health equity and ensures that all mothers can achieve optimal health by addressing poverty, improving healthcare access, and combating discrimination. The services are listed on the right. For the Maternal Child Health Program can be reached at our hotline listed there via and our email as well for any general questions, inquiries, or referrals you may have. Thank you for your time, and it is a pleasure to share this space with all of you.
Our next panelist is Ms. Renee Eddings. Renee is a seasoned nursing professional from Houston, Texas, with a wealth of experience spanning over 20 years. She earned both her Bachelor of Science in Nursing and Master of Science in Nursing Administration from Prairie View A&M University. Over the course of her career, Renee has demonstrated versatility in her roles within women's services, with 15 of those years spent contributing to the success of Harris Health. Her dedication to the nursing field, combined with her broad skill set, makes her a highly respected and well-rounded leader in the healthcare community. Ladies and gentlemen, Ms. Renee Eddings.
Good morning, everyone. We are happy to be here, and I'm happy to be here to represent Harris Health. We have just a few little things that we'll speak about within regards to what Harris Health System offers for our patients within the community. But first, I really want to hone in on what our vision and our mission is within the Harris Health System. Harris Health vision is to become the premier public academic healthcare system within the nation. As far as our mission, it's Harris Health is a community-focused academic healthcare system dedicated to improving the health of those most in need in the Harris County through quality care delivery, coordination of care, and education. And we really are focused on ensuring that we are providing that quality care to our patients within the Harris County community. So within Harris Health, we have, is also noted as the 4th largest public healthcare center. We have 2 acute healthcare facilities. We have Bentob Hospital, which is located in the medical center, and then we have Lyndon B. Johnson, which is located on the north side of town. We have level 1 and level 3 trauma centers. Within that, we also have level 3 and level 4 maternity healthcare centers within our system as well, with a level 3 at both of our facilities, neonatal care facilities. 15 community health centers that feed into both LBJ and Bentob. And these community health centers are located all around town. 2 pediatric adolescent centers. We have 3 same-day clinics, and we have also specialty care clinics where we have oncology care clinic and outpatient rehab and dental services that we provide as well. We also have the nation's first freestanding HIV treatment center, where we also see and have a special obstetrics section within that as well. Healthcare for the Homeless program, where we have 7 clinic sites around the Houston area, and we have now partnered with Correctional Health. So we also provide medical care for our Harris County Jail Correctional Health patients. So at Bentob, I am the director for labor and delivery at Bentop Hospital, so I'll focus a little bit on Bentop. However, I do want you to keep in mind that Bentop and LBJ maternity centers work very closely together. We want to ensure that we are providing the care across the system as a whole, so no one is being shortchanged or any of that nature. Our patients are getting the same care in the medical center and on the other side of town as well. So we try to ensure that we are making sure that we are one system as a whole. Here at Bentop, we have a Texas Health Step Clinic. That clinic provides an opportunity for the mothers to bring their babies, their newborn babies, in for their newborn checkups within the hospital that they delivered at. We have a lactation clinic at the time that they do come for their Texas Health Step Clinic for their pediatric care. They're also seen by a lactation counselor. They're able to get assistance in regards to breastfeeding if they're having any complications, and they can get that real-time assistance at that time. We have 2 care by parent suites, and I'll come back to the 2 care by parent suites. We have employee lactation rooms where we offer our employees an opportunity to continue to breastfeed once they return back to work. We have a postpartum follow-up clinic. This postpartum follow-up clinic is actually new. And what this postpartum follow-up clinic offers is that our patients who bring their babies back for the Texas Health Step Clinic for the newborn to be seen, the mother is seen. The mother's blood pressure is taken at that time, and follow-up care is provided at the same time. Because what we do realize is that a lot of times our patients, because we do serve the underserved population, that they have limited resources. So the back and forth to the hospital is taxing on those parents. So we try to collaborate and to bring it all together so that we can get them serviced at that one time. So they're at the postpartum follow-up clinic, they have their blood pressures taken. If there's any issues with their blood pressures, we're noticing any issues postpartum-wise, then we can have them followed up in our OB intake area and be admitted if needed or evaluated appropriately. We have midwifery services as well. We have childbirth classes that are offered within our clinics. We have centering pregnancy group education, and this group education is also offered within our clinics with that feed into Harris Health, to LBJ and to Bentop. We have virtual and in-person OB tours. So we allow for our moms to come in, families to come in, and they have a guided tour to see what the labor suites will look like, what your postpartum experience would be, and also the clinics as well. And then we also have a maternal opioid misuse program, which we call MOM, and that ties back into my two by care parent suites. The maternal opioid misuse program is a program that we've put in place that allows for us to treat and to coordination of care with moms who are substance use dependent. So we have a clinic that they are seeing in on Wednesdays and Fridays. These patients come to those clinics. They are treated with medication. They also have other services that are provided in order to ensure that they're having a healthy pregnancy and a healthy delivery and a healthy postpartum period. We partner with Santa Maria, and they are sometimes discharged back to those facilities as well to continue that care. When they have the 2 parent suites, they are also being able to stay with their babies throughout that time, right before discharge to kind of bridge that care. So this is, one more thing, just to kind of brag on Bentop for a little bit, we were voted the best maternity care centers for 2 years in a row. Thank you all. Thank you all for your time.
Our next panelist is Ms. Heather Butcher. Heather began her social work career in 2007 as a foster care / adoptive coordinator at Arms Wide Open. In 2010, Heather started their DSHS-funded parent education program, servicing families in the Corpus Christi and Coastal Bend area. Following that, she served as an elementary school social worker in Corpus Christi ISD. In 2012, Heather transitioned from direct services to macro social work, serving as the maternal and child health director for the Gulf Coast March of Dimes for 10 years. In 2023, Heather moved to the American Heart Association, where she currently serves as Vice President of Health Strategies for the Greater Houston region at the American Heart Association. There, Heather leads the community impact team in implementing 100 years of heart health research and programming throughout the greater Houston area. Ladies and gentlemen, Ms. Heather Boucher.
Thank you. Thank you all. I am so glad to be here today amongst a lot of familiar faces from my previous life. And here today, I've been at American Heart Association for about 2 years now, so excited for that. Our mission is to be a relentless force for a world of longer, healthier lives. And I think what I left off of there, this one is for all people. And so here today, especially, we're talking a lot about African American and Black families and what we can do to better serve them, specifically here today during pregnancy. And we know the health disparities and the adverse outcomes that come out of maternal circumstances. And so I'm really proud of this organization, how we've stepped up in the last year in a number of ways, or not in the last year, over the last several years, to increase our research. Thank you, Dr. Plenty, for the shout out of that wonderful research that we're starting to do. So I'll talk a little bit about that as well. We have a lot of work to do, and this is, I think, I use this as just a talking point slide about where we've come. Like they mentioned, we've been around for over 100 years. We're going into our second century right now, and we've learned a lot over those 100 years. We are a research-based organization with a small but mighty team here in the Houston area that I'll introduce some of them here in a moment. But so what we're doing is taking, like I said, this 100 years worth of research. 2010, we saw this amazing decrease over the years through 2019 in cardiovascular disease and death. And then what happened in 2020? A great surge that we are still recovering from. And so we're pivoting our research to see what are those long-term effects of COVID, because we all know that that's part of that spike there. We've seen it drop a little bit recently in 2022, but what can we do to address that? What we do as an organization, we're a convener and a collaborator. I can say with honesty, we don't do any pure direct services. We have a staff of public health team that go out and create programs based on our research. But this is really how we visually try to explain what we're doing throughout the community. And I'll talk about more specific what we're doing in Houston. But our main focus is equity. Everything is out of an equity lens. And so our team really tries to look at, even within Houston, what are these micro communities that we need to service and meet their needs around cardiovascular health. And I can say we do a great job of that in listening and then taking what the resources we have out into the community. Many of you have heard about our Go Red for Women campaigns and research that came out of how men and women differ in their heart health and how that needs to be addressed. And so we'll talk a little bit more about what that's pivoted into over the last year with us. Addressing those community needs, readiness for preparing consumers and for their health concerns, making sure that the public in general is aware of the differences between heart attacks, between men and women, those symptoms to look for. So we do a lot of public health education through social media, flyers through our partners at events to make sure they know the questions to ask and are empowered when they go to see their providers. Ending e-cigarette and tobacco use. This is so huge, and we're doing this in a number of ways with the schools and really trying to educate more about vaping. You know, as public health is just this cycle of where we addressed smoking for so many years and people quit smoking, so now they're vaping. And so that's our, and so when people quit smoking, of course, we defund it. And so now we're addressing that. Controlling blood pressure. I think that's the thing we're known the most for. We have an amazing clinical-based program that's data-driven that Veronica Sanchez is here. She's our senior director of clinical systems. She has almost 300 clinics throughout the Houston area that implement what we call Target BP and also a diabetes and cholesterol program with that. And really the focus is educating providers on how to educate their patients on blood pressure. So empowering those physicians to know how to be able to speak on that patient level about what is blood pressure and to be checking it at home and monitoring it and taking your medications and all those things so that you can hopefully get off of that medication. And then healthy living. I did not know this when I got to American Heart Association, but we have a huge part on nutrition security. So here in Houston, our focus is improving blood pressure with those clinical skill-based programs that really involve patient education, increasing nutrition security, and that's a great arm that we want to talk more about at another time, responding to those critical needs in our community, and reducing risk for women. Over the last year, we've been hosting maternal health roundtables. We've been listening to our friends in the community, working with our partners like March of Dimes, the Preeclampsia Foundation, Nurse Family Partnership, bringing them to the table and saying, what can we do for cardiovascular maternal health? In one meeting, I remember a nurse said, if I had more blood pressure monitors in homes, I could save more lives. And we took that to heart. So we've launched a program called MomRx. We have 5 clinics across Houston and community-based partners, both. They're going to be implementing that program. There's a trifecta that we look at around that, where we address both working with the physicians, educating on that self-monitoring patient-based blood pressure, physical education, and then nutrition education with it as well. And so we're really excited to be bringing that to the community and look to visiting with more of you about that. So thank you.
And now I'll be introducing our moderator for the panel. Our moderator is Dr. Charlie King. She's an experienced, seasoned healthcare professional with over 9 years of experience specializing in lactation and maternal and child health for 7 of those years. Her journey towards earning her DRPH began after graduating from Texas Southern University, where she pioneered the creation of the university's first lactation room called the Mommy Room, which brought awareness to the needs of such rooms. And in 2023, she formally started her company, the Mommy Room Lactation Suites. In 2018, she founded Mommy's Sweet Treats, and a lactation health company dedicated to providing lactation treats and accessories. Charlie is also the author of Thanks for Telling Me, a comical guide for new mothers, drawing from her own experience and near-death encounter during childbirth in 2015, which ignited her passion for maternal and lactation health. Please welcome Dr. Charlie King, as well as our other panelists will come on board. We're going to bring up our other panelists.
All righty. Hi, Dr. O. We had like a little moment. Yes, I completed the maternal child health program actually under Dr. O, so that's what that moment was about. So before we get started, I want to know if there are any questions from the audience. I know they gave some great information about the maternal child health resources and services they provide. So are there any questions for the audience, from the audience? Yes, ma'am. You got the mic.
Hi, my name is Elizabeth Shaver. So in another life, I worked for DSHS. I was a community health educator and monitor. And I tracked 19 women of varying, I guess they were multiracial households, but these were all women in varying degrees, first mom, second mom, fifth mom. And they all had very extensive health histories. All of them, the common denominator for all of them were they were HIV positive and living healthy lives. Unfortunately, they contracted a secondary or tertiary STD, STI, including congenital syphilis. In my travels over those years, and I named 19 women because those 19 women died in childbirth. It was very hard for me to see that. The one common thing in those years that I found is what are we doing about cultural and linguistic intake for our patients? I sat with many women, more than 300, and the one thing is their common always was, take off your lab jacket and just talk to me, you know? The way that we take in our information when we're doing intake, I'm wondering, is there anybody in the room that does that? I sat with residents at Baylor College of Medicine in OB-GYN. They were working to be OB-GYNs. And the first thing that I asked them about was, what is it going to be like when you ask about, their sexual history? And it was crickets in the room. So I'm wondering how can we do better to work with the community, and not only bringing up that level of trust to share that delicate information during childbirth, and not just around sexual health, but all health history. And is there any programs, is there anything that anybody's working on to generate more advocacy around creating, access to getting better intakes done? Because that's where the conversation starts.
Okay, so if you could just give
one question.
Yes.
Yeah. So, is there anything going on in the community? I work within the community as a community health worker. Is there anything going on about looking at intakes and or studies around intake, and what that might look like when we're trying to reach communities that sometimes are distrustful of the health profession, let alone, especially in maternal fetal health?
So, this is Ramatu. I know the Nurse Family Partnership and the Healthy Families Houston programs, when they initially meet the clients, you mentioned one thing that I think is really key is building that trusting relationship and having those conversations and really meeting and sitting down with the clients. So their intake process is very personal, because our goal in those programs is to build that long-term relationship until the baby is 3 for Healthy Families and 2 for Nurse Family Partnership. So we want to be able to have those conversations with the clients, right? We have a curriculum and things that we want to go over with them, but if they're not able to be as transparent as they can be, so that the team of nurses and care, the providers are able to really meet some of their needs, or even be able to find a resource that's able to support them, it really makes the relationship very superficial. And so for those particular programs that we have at the Houston Health Department, and there are other Nurse Family Partnership programs here in Houston as well, it's about building those relationships so that they can have those conversations and really get to the root cause of everything. Because at the end of the day, we want to see the clients not just graduate and be out of the program, but to be self-sufficient, to be healthy, to be able to take care of their kiddos and themselves. And some of them are also taking care of their families. So it's about building that relationship. And I know those 2 programs certainly work to build that relationship within the initial visits and as the visits go along, so that they're able to provide them with adequate support.
And it was a great question, by the way. So are there any more questions? Yes, ma'am. Use your mic. And state your name for me if you don't mind.
Yes, my name is Janice Pender. I have a question. So, and for anyone, relating to maternal and child health initiative, how can a church or a faith-based organization really participate in exercising, getting the information out, getting the congregants or the people or in the community? How can we participate with that? What are some things that maybe that you see that we can do and leverage with our the amount of people that we are in contact with each and every Sunday? What are some things?
I can say that focusing on the Black Maternal Health Week nationally is one way that we can reach our congregation. I think working with your health and wellness ministry and ensuring that we have people partnered connected with the right people to bring that information within the church. And as we're doing announcements on Sundays, or you have your programs, you can place that kind of information within your programs or your announcement boards, or however you disseminate that type of information. But I think focusing on we have mental health day, those kind of things, just kind of bringing out what the nation is already recognizing, and then also incorporating that within our congregation as well.
You have one more question in the back.
I don't really have a question. I just had a couple of comments to the two questions that were posed. I know intake can be tricky. People don't know you when they're coming in for services and they're meeting you for the first time. So one thing that you can do to make them feel more comfortable and take advantage of resources, some things that they do say and come in for are shocking. So try to monitor and be mindful of your gestures and your facial expressions, and just have information on hand that you can give them. Sometimes things are seen that don't have to be said, and so just pay attention to how they're presenting when they come in and offer as many resources as you can. The second thing is, if the language is a barrier, most places have a language line or other persons who are certified to speak those languages. So invite them in to assist if you can, and don't try to push through it. The other thing is, for the churches in the community, I know that Catholic Charities, Wheeler, Trinity United Methodist Church, people come in all the time for resources concerning bills and things like that. So just build up your your resource base, and have things on hand that you can offer for shelters or other programs. I brought some leaflets here today for Nurse Family Partnership. And so just have those things there that you can, pass along to them. So if they know anyone who needs them, or if they need them, they have them, so that it's a daily invite for them to take advantage of resources.
Thank you. Yes, ma'am. Bring you the mic. The mic. I'm giving you the mic. I can hear you.
Oh, okay. Hello. I just wanted to thank all the speakers and that delivered valuable information. But that's what it is, valuable information, and it was a lot. And to make a suggestion on the ladies who brought forth how can we help, what can we do, how can we solve these things, I just have a suggestion through the church. How about having a health hotline, so that when someone calls, they can be given the information that pertains to them particularly. As for an example, give the phone number, give the address to where they can find out how they can get help with lactating, or how can they find out where, hey, I'm uncomfortable. My doctor's not listening to me. Do you have some suggestions of other physicians in my neighborhood, near me, near where I live? So that way that person can immediately get the address, get the telephone number, get the email, and then go forth with it immediately. And so, and not just covering only maternal child health, but heart and any other health issues, and just label it health hotline. And that would be good, working through the churches, because mostly everybody here has a church or a religion or a faith. And so they can just go to that point and then get immediate information where they can get help immediately and start working on it immediately.
Thank you. We have one more question in the back. And this will be the final question from the audience.
Hey, good morning. My name is Janae Johnson, and my question really is for anyone on the panel. I'm curious about if any of these organizations are leveraging emerging technologies to really scale this effort beyond just the people that you can reach and touch based on the headcount that you have in your organization. So specifically, are you using like Gen AI tools, or is there any research around that maybe you all are exploring that? Because what I see is there's such a wealth of resources, but there are only so many people, and there are far more women who need the support than what any of us can actually touch, and technology being a pathway for that. So I'm just curious if any of that work is underway in any of those organizations.
Yeah, I can speak from a national level in our Target BP program. You know, we process a lot of data. We're adding questions where they break it down by ethnicity, different, you know, how they're treating, and using AI to process that a lot further is in the horizon for us. Working with local healthcare systems too, especially healthcare providers have been a big partner of ours, and trying to process all the data de-identified that they have access to is a priority locally too, so that we can better look at pertaining to today birth outcomes and things like that. Veronica, did you have a statement too? She can help me answer that as well.
There we go. I'm a little short. What I also wanted to thank you, Heather, for that. What I also wanted to share is that the American Heart Association is entering into our second century. In other words, we're hoping for another 100 years. And as we advance, one of the questions we look at is how do we leverage and utilize AI moving forward as it relates to healthcare? We have a division related to technology, and one of the things that we're experimenting on is cuffless blood pressure monitors. So that's something that's coming. We have researchers doing that right now, and so more to come. But I just wanted to say that we are on the cutting edge of technology and moving the needle forward.
Sorry, there was one more question online. They're wanting your contact number, Heather.
Oh, yes. You can email me at heather.butcher with an S in the middle at heart.org. And I'll make sure. And Veronica and I both have some cards we can give you as well.
Thank you for the questions from the audience. I actually have some questions. And Heather, I want to start with you because I must admit I was actually taken aback when I think of American Heart Association. Tobacco is the first thing that comes to mind, or cigarettes and things like that. So to find out that you actually have services for maternal child health was very interesting to me. So my first question is, can you provide any examples of recent programs that y'all have in place in regards to maternal child health?
Yeah, so nationally, knowing the numbers, especially here in Texas, around cardiovascular issues tied to maternal deaths, we knew that we had to step in. That started nationally with materials. So educational materials are available on our website. We can provide those to you all. Here locally, it was really knowing the scope coming from March of Dimes, knowing the scope of work that's already out there and the synergy that we have in Texas around improving maternal health outcomes specifically for Black women. It was where's our lane? And our lane is cardiovascular maternal health. Again, knowing that we needed to come to the table. So it was really, we've done a year worth locally of listening to what those issues were. I mean, many of the issues were barriers to access to care. We saw the statistics on, 40% of women aren't getting into healthcare early on. We have some great barriers around getting on Medicaid quickly. There's loopholes in the, being able to see a provider while you're applying for Medicaid. So what can we do, and what we're looking at is how to get those in patients in earlier. And so we have a number of community to clinic partnerships that we're building out with organizations like Nurse Family Partnership and great partners out there, taking that research that we've done tied to specifically blood pressure, but what we'll be doing through this, we have a research arm of our Mom RX program. U of H is going to provide some of the research around that. How can we take all the information that we've learned about blood pressure and start applying it to pregnancy over the next year? So Houston is being looked at very closely. The work that we're about to launch in the coming month is going to be looked at really closely. We want more feedback. We want more input because we're really building the plane as we're flying it. So we've listened. We think we know what we're doing, but we know there's always going to be a lesson learned going forward. So looking forward to working with you all as you all help build that out.
Thank you so much. And unfortunately, we are out of time. But again, ladies, thank you so much for all of you guys stay to the end so you can talk to these ladies, get their business cards and information if you have any more questions. Okay? Thank you, guys.
Thank you.
Good morning, everyone. Welcome, welcome. Thank you for joining us today. My name is Virgil Elkins, proudly serving as the project manager for the TSU Community Engagement Corps Center for Biomedical Minority Health Research. And I had the pleasure of introducing the next student group here, which is the TSU debate team. The debate team is an internationally renowned. The TSU team is internationally renowned. Started under the leadership of Dr. Thomas Freeman more than 70 years ago, the team attracts approximately 25 to 50 students annually. Students may be introduced to the forensic arts for the first time or continue involvement with debate activities that may have been started in high school. The debate team office is a popular tourist attraction for visitors to the campus to see thousands of trophies won by the team and numerous photos of students in competitions around the world. Other memorabilia in the office attest to the popularity of this campus organization, the certificates of achievement, merit awards, and proclamations from national dignitaries. Please give a round of applause for the TSU debate team.
Each year in the United States, hundreds of black women die during pregnancy or in the year after.
Thousands more have unexpected outcomes of labor and delivery with serious short or long-term health consequences.
Every pregnancy-related death is tragic, especially because more than 80% of pregnancy-related deaths in the U.S. are preventable.
Recognizing urgent maternal warning signs, providing timely treatment, and delivering respectful, quality care can prevent many pregnancy-related deaths.
The Texas Southern University debate team is proud to present this Reader's Theater presentation, scripted especially for this occasion by head coach Dr. Gloria Baptiste Roberts, entitled, Everyone Has a Role to Play in Promoting Black Maternal Health.
Black women are 3 times more likely to die from pregnancy-related cause than white women. Multiple factors contribute to these disparities, such as variation in quality health care, underlying chronic conditions, structural racism, and implicit bias.
Social determinants of health prevent many people from racial and ethnic minority groups from having fair opportunities for economic, physical, and emotional health.
We must all work together to reduce black maternal mortality. Learn how you can support pregnant women in your life to reduce factors that contribute to pregnancy-related complications and/or death.
Pregnant women and their families can talk to a healthcare provider if anything doesn't feel right or is concerning.
Know and seek immediate care if experiencing any of these urgent maternal warning signs, including severe headache, extreme swelling of hands or feet, trouble breathing, heavy vaginal breathing or discharge, overwhelming tiredness, and more. These symptoms could indicate a potentially life-threatening complication.
Share recent pregnancy history during each medical care visit for up to 1 year after delivery. Connect with healthcare and social support systems before, during, and after pregnancy.
Healthcare providers can hear what patients are saying. Listening can be your most important tool.
Hear her concerns. It could help save her life.
Healthcare providers should ask questions to better understand their patients and things that may be affecting their lives.
They seek patients and help them, and those occupying them understand the urgent maternal warning signs and when to seek a medical attention right away.
Healthcare providers can help patients manage chronic conditions or conditions that may arise during pregnancy, like hypertension, diabetes, or depression.
Healthcare providers can recognize and work to eliminate unconscious bias in themselves and in their office on an ongoing basis.
They can respond to any concerns patients may have.
Healthcare providers can provide all patients with respectful quality care, irrespective of their race or ethnicity.
Hospitals and healthcare systems can identify and address unconscious bias in healthcare.
Hospitals and healthcare systems can identify and address social factors influencing maternal health, such as unstable housing, transportation access, food insecurity, substance use, violence, and racial and economic inequality.
Everyone has a role to play in promoting black maternal health. The Black Mamas Matters Alliance serves as a national voice and coordinating entity for stakeholders advancing maternal health, rights, and justice.
The Black Mamas Matter Alliance is a national network of organizations and leaders from the maternal health, human rights, and reproductive justice fields who believe that everyone deserves access to quality and holistic health care.
Black mamas have always been the guide and bridge for families, communities, movements, and the waves of change.
The time is now to invest in the advancement and the movement for racial and birth justice.
The historical atrocities are deeply rooted in racial and reproductive oppression, bent on controlling Black liberation, and must be countered with community, advocation, and prioritizing Black mamas across the African diaspora.
Everyone has a role to play in promoting Black maternal health.
Amita Parker shared a poem entitled Just Help Me, a research poem by Black mothers that tells the stories of the maternal health and support experience of Black mothers in the Midwestern metropolitan context.
Several excerpts from that poem include,
And when asked about my mental health, I replied, I had it until apparently I didn't. I was stressed at an all-time high, and I cried and I cried. I thought I was going to die.
Another mother said, pressure from every direction. It's a lot, all the time. Because of that, you just get tired, period, of life, just feeling heavy all the time.
Another mother said when asked about support for her mental health, she said were many things that came to mind. I have some things that are like a root to my life, like some people in my life and God. They have supported me during very tough times. Everyone has a role to play in promoting Black maternal health.
If I could just have more me time, that would help my mental health. I need time, period. Just time to listen to music, time to cook, or time to lounge, whatever. That stuff is calming to me. When my mental health is at a bad place and I'm really kind of vulnerable, trying to deal with stuff on your own, that's a real headache too.
Everyone has a role to play in promoting Black maternal health. If there were some type of support groups for Black moms, that would be helpful.
What about a mental health life coach? Is there such a thing?
Someone that can guide me. You know what I'm saying? Maybe a talk line to call if you feel like you're stressed. Someone who could be there for anyone, anytime, anywhere.
Everyone has a role to play in promoting Black maternal health.
Everyone has a role to play in promoting Black maternal health. Everyone has a role to play in promoting Black maternal health.
Thank you so much, TSU debate team. We appreciate you. Thank you for lending your voice. Thank you. We appreciate you all. Thank you, everyone, for your patience with us, and thank you all for this information. Speakers, panelists, guests, we thank you. Just a few housekeeping rules in the middle here. Please do, we encourage you to please help us to give us your feedback by scanning the QR code. Somebody mentioned technology, how are we leveraging technology? Please, we're leveraging it this way instead of papers. But we can use paper surveys. If you do want it, please raise up your hands and we will definitely give one to you. Otherwise, please let's leverage technology by giving us your honest feedback. We use this to create the year's calendar. Want to also appreciate, remember, for those community health workers who want CE credit, please go ahead and sign up for that one. We will definitely get back to you in the next 2 weeks. Dr. Plenty, your information was wonderful. Please expect an email from us. We'll be sending you questions that we need answered. And to our online participants, we promise to please put it on our link tree for you within 2 weeks with Dr. Plenty's responses. Want to thank all our partners, our sponsors, our vendors. Because of time, sorry, I will not be able to call you out one by one, but please know that we do appreciate you. We appreciate your time. We appreciate your effort. You could have done or be anywhere else, but you chose to be here with us. We really appreciate it. We have a 5-minute break for you now, just probably enough to just stand up and sit down. Because if you go out, I don't know, but please, we do have the next session coming back in the next 5 minutes for another information on our different programs here at Tech and Southern University. Thank you. So just shake those legs and thank you. All right.
Howdy, everybody. We're going to be starting real soon again, so if people are able to find their seats again, that way we can go ahead and return back to our Maternal and Child Health Conference. Thank you so much.
Yep. Ladies and gentlemen, can we get you to get back to your seats? I know we like to fellowship and let each other know all of the great things that we're doing. Thank you so much. Now I would like to introduce a lady who is the catalyst, as Dr. Ajuale Mwemwe put it. Dr. Omanike Alaleye is a professor of pharmacology and the Senior Associate Vice President for Research and Innovation at TSU. Her formal training in pharmacology and epidemiology were at Johns Hopkins University School of Medicine and Harvard University. She has expertise in pharmacology and epidemiology research spanning over 20 years, working on research focused on diseases that disproportionately affect underrepresented minorities. She is the PI of the $8.6 million RCMI-funded Center for Biomedical and Minority Health Research. Dr. Olaleye is also the PI/PD of the $2.42 million HRSA-funded MH REACH, Gulf Coast Collaborative Center for Maternal Health Research, Education, Advanced Training, Community Engagement, and Health Equity and Justice. Please give a round of applause for Dr. Olaleye. Thank you so much.
God bless you. Thank you so much. Wow, we're so blessed to have you here today. And I bring greetings from our team, and some of them are here. And actually, let me start with that. I know everybody's clapping for Dr. Laleye, but they do all the work. Let's give it up for our maternal health research team. Guys, can you please stand up? We're small but mighty. Come on now. Our CEC team, all the maternal and child health workers, come on now. Give it up for them. Thank you guys for all your great work. You know, sometimes we're working so hard, staying up till 10, 11 p.m. And I remember Jasmine is like, Dr. Oh, can we go home? Then Cecilia is like, I got to go rock climbing. I'm like, no rock climbing today. So we're super blessed to have such an amazing team at TSU. And of course, we're not the only team at TSU working on maternal health. So this is awesome. So here, I'm here to just share briefly. You hear from them directly all the great work they're doing. I'm just representing the center that focuses on maternal and child health, mainly the Gulf Coast Collaborative Center for Maternal Health Research, Education, Advanced Training, Community Engagement, Health Equity, and Justice at Texas Southern University. It's a long name because we do a lot with so little. So we got to put it in there so that as we attract all this funding, we can actually move the needle. These are the main goals of our center. Of course, we were super blessed in October 2023 already, right, to have established this center in collaboration with our partners at the Medical Center, as well as my colleagues here at TSU, which you hear from shortly. And our focus is on two main projects. And I love what you said, Dr. Butcher and Veronica. We actually partnered recently with Veronica. Where is she? She was sitting next to me because we had not met in person before. Give it up for Veronica, please. We submitted a big Arrow 1 grant in November. Last minute, we reached out to U of H. They connected us with her. But our center's focus is really at the core of the main diseases that kill Black mothers. And we said under our watch, the numbers have to go in the right direction. And so 2 of our projects focuses on hypertensive disorders of pregnancy, one using secondary data analysis, AI tools, and then Dr. Ajewale is going to speak on what she and Jasmine has been working on, looking at medication therapy management, which would not only focus on antihypertensive drugs, but also looking at all the medications that the mothers are using. And of course, Dr. Pounds, give a shout out to Dr. Pounds. She'll be speaking about her pilot project. So we're inviting the community partners to apply to those small pilot projects. We're going to partner you with early stage investigators here at TSU to really deploy solutions to our community. Enough of the talking, enough of the analysis by paralysis or paralysis by analysis. We need to actually deploy solutions. And I just always like to say, this is how we started, okay? This is how we started, and by God's grace, we got nationally recognized, and now the government is bringing us to the table as they make decisions. So we started out with a cohort of students in partnership with Baylor. We had a very small grant at that time from HRSA, and we had that program for 5 years. To date, we've trained almost 125 students in this program. Yeah, give it up for TSU, because guess what? Unlike other schools, we do not have a school of public health. Unlike other schools, we do not have an MCH program. So we do really make lemonade out of lemons. And we were able to train this 125 maternal child health students from 10 schools and colleges. And Charlie can give it up for Charlie. She is one of our products, and I'm so super proud of her. Lariana, she's one of the leaders at Harris County Public Health. She was from our program. Several of our students leading health departments across the nation, not just, so we're super blessed to have been able to do that. Above all, I think one of the greatest things for the students was they were able to publish over 20 publications as first authors, undergraduate students at TSU. Give it up for them. And I would remind them, so it was an extra curricular class. It wasn't part of their curriculum. So they would literally be in those rooms till 10 p.m., 11 p.m., students from different areas, music, social work, pharmacy. And I would remind them, guys, you are learning what I learned at Harvard on a master's level. You're learning it on undergraduate level between the collaboration with Baylor and TSU. So those students actually published the work interrogating over 60 million pregnant women in this country. And so we were able to do that. And in addition to that, worked with our partners across the country to show this model so that this could be a framework for other schools that actually have more resources and partner with us so that we can have our own school of public health. This is the team that makes it happen. So in this new grant that we just got, we have a huge team. So let's give it up for Cecilia, Dr. Poon, Dr. Ajewale, Kennedy, Dr. King, Dr. Gwen, Dr. Pounds, Dr. Idowu, Dr. Jasmine, Dr. Oluyomi, Oloruyomi, and Sneha. So this is a very transdisciplinary team from our different schools and colleges at TSU. We received this award, and recently, last October, the U.S. Commission on Civil Rights invited us to be part of the report they'll be turning into the president. So that happened to us in October. We were one of the 4 schools in Texas that was picked because this is a crisis and they know the people that are actually doing the work, and they put together that report for the president to make decisions on how can we really move the needle nationally. Our work was also featured globally. We got a call from London from APHA TV. So you can go, we have, it's on YouTube, to discuss all this great work that we're doing. Also, this team does not stop. Give it up for them. So not only do they, do we work on maternal health, but we're now
really blowing up the skills at TSU and looking at, public health, data science, AI, bioinformatics, and these are staff members. These are not faculty. They are staff members that actually went after this grant to get this $0.4 million supplement from the NIH. Give it up for them. And they're teaching not just students, they're also teaching faculty and staff, because we know that it takes all of us to really be on top of public health in this country. So this is a structure of our program. I'm running out of time. Just to show you that we have a structure, everybody knows what their job is, and of course we can't do it alone, so we're working with different groups. More importantly, we have a community advisory board. Dr. Pounds will say more about that. And we have this great, amazing Voices of the Pregnant and Parenting Work Group that has been such a blessing to our program. So not only do we listen to the community, we have people with lived experiences at the table, doulas, all kinds of people like Dr. Plenty mentioned, for us to bring our minds together. Because guess what? I always like to say this. Everybody's doing great work. Everybody's trying to move the needle, but clearly something is not working. We need to come together to make it happen. At TSU, we realize the opportunity we have to really be the one to push out the pipeline. Like Dr. Plenty mentioned, HBCUs make great health professionals all over the country. And so our goal is to really make this, increase the pipeline, increase the workforce for this maternal and child health program. So this is our framework. It's on our website. I won't spend too much time on the data. We've heard so much about it. Harris County, you all know that Texas has the highest number of mortality in the nation. Okay, yes, Texas is big, but we don't want to be big for things like that, right? And so, but it's going to take all of us to do that. Dr. Ajewale will speak more about her medication therapy management. She did such a great work. Give it up for her, Dr. Ajewale. I can never forget her first day in my lab. And I'm so blessed that I kicked her out of my lab and said, Doctor A, it's time to get out there from pharmacy school. And then she got into MD Anderson Cancer Center to do research, and she just kept growing. And I always reminded her, don't take my job. But girl, come take my job now. I'm so proud of what God has done in her life. And training and bringing on Jasmine, our TSU alumni. Where's Jasmine? She's very shy. Stand up, Jasmine. Jasmine is our one of our postdoctoral fellows, and she hit the ground running. We submitted together a big Arrow 1 grant, and Jasmine was a lot of the brain behind that grant. So we're so proud of you, Grace, Cecilia, Dr. Idowu, all our team from TSU and U of H as well. Dr. Dowu will speak about his research work. He's a genius. I can never understand what he's talking about. So much. I'm serious. I had to go to UT Health and get their chair of bioinformatics. Come help me. Let's mentor this dude together. He's too smart for me. But he's had like 4 or 5 grants just hitting the ground at TSU. Got recently promoted to research assistant professor. Dr. Dowu, we're proud of what you're doing. The DOE is coming after us. Department of Energy. EPA just set up in our lab. We're so blessed because we have this hardworking, talented people at TSU. Now, like I mentioned earlier, to make this happen, we have to bring all the key stakeholders to the table, like what we're doing today. So we were blessed to have our friends from UTMB, Dr. Kathy Vincent. Give it up for Kathy, because anytime I call her, I'm like, girl, we need some help. And just everyone, all the different agencies, Harris County Public Health, Houston Health Department, all the different agencies, academic institutions that have come together to really help shape. Because I did tell the team this time, and as much as I like to hit the ground running, this time I'm like, something is not working. So we cannot just hit the ground running. Let us see what are the best practices. What can we do together? What is sustainable? What is scalable? Anything I do has to be sustainable, scalable, and what is the other one? Has to be structured, right? It has to be something that we can really blow up, because it's going to take more of us to move the needle. And so I think that's it. If you're interested in joining our center in any capacity, as a partner, as a staff, as a postdoc, as a sponsor. Oh, look at Dr. Ajewale. As a sponsor,
please go ahead and use that QR code to learn more about the great work that is happening at TSU. Thank you so much. I've been so blessed to be at TSU. This is my 17th academic year, and I would say TSU is a gold mine. And we have to, what changes the world is gonna start here. And we really have to prevent Black mothers from dying. And it's in your hand and my hand, and coming together will make this happen by God's grace. Thank you so much, Dr. Ajole, for hosting this conference. Thank you all for coming. Truly appreciate you. Oh, the video, there's a video.
Hello, I'm Monique Olaleye, Director of MH Reach, a center focused on advancing women's health through research, education, and community engagement for underserved populations in the world's largest medical center.
To date, we've trained over 125 maternal health professionals with over 20 publications by analyzing over 60 million women in America.
We have provided several health education conferences reaching over 1,000 people. With the Action Grant, we will scale up the integration of mental health services to promote holistic well-being through licensed professional counselors and social and community health workers.
MH Reach is implementing medication therapy management, mental health services, and cultural healthcare models for refined care. We focus on improving health among underserved minority women during prenatal, pregnancy, and postpartum.
Our innovative approach uses advanced biomedical and epidemiological tools focused on community-driven solutions and strategic partnerships for transformative change in women.
Using advanced AI tools and development of women health toolkit will lead maternal health research, reduce disparity, and ensure quality healthcare in the region.
We empower women, healthcare professionals, and families through community and global health education and advocacy.
Through culturally responsive training, we are increasing the maternal health pipeline and workforce and creating sustainable models for global impact.
Together we create systemic, national, and global change.
Transform maternal health,
improve women's health, and advance health equity.
and ensure that every mother not only survives but thrives. Hello, I'm Monique.
Okay, so our next speaker will be Dr. Kehinde Idowu. He's a research assistant professor here at TSU with expertise in molecular biology, biocomputational science, and artificial intelligence research. Through the TSU Leadership, Education, and Advancement and Undergraduate Research Pathways program, Dr. Idowu was appointed as the faculty member specializing in artificial intelligence and machine learning. He has provided TSU students with hands-on research opportunities, teaching them concepts and applications in data, science, maternal and child health-related research, drug discovery, and more. Recently, Dr. Idowu established the Biomolecular Research and Advanced Computing Center. This center focuses on training in AI/ML and advanced computing and biomolecular research. Please welcome Dr. Kehinde Idowu.
Thank you. Good afternoon, everybody. We are really glad to have you in TSU. So my name is Kehinde Idowu. I'm a research professor. I've been working with Dr. Monique Olaleye, and we've been doing some research. We are considering the incidence of death among Black women in Texas. And unexpectedly, US is an advanced country, and we do not expect as much as that. So our center has been focusing on looking at disparity and providing solutions to these issues. So I'm going to present one of our projects that has to do with understanding trends and disparity in hypertensive disorder of pregnancy in women. So hypertensive disorder of pregnancy is a predominant situation that happens among women. I personally have experienced that, through my wife. And, and it was, to be sincere, it's not a situation that someone should be. I had to sleep on the hospital bed for like a week. You know what that means? Yeah, trying to make sure everything. And at the time she was sleeping, I'll be monitoring the BP monitoring and make sure everything is fine. So we don't want anybody to experience that. And we have centered our research looking at this situation. And this is one of the second leading cause of global maternal mortality following maternal hemorrhage. and this disproportionately affects black women. We are not only concerned about black women, we also have interest in other races, but because of the predominance in black, African American, and Asians, and the rest. So in this project, we are focusing basically looking at data from CDC and also data from Harris County. And we have been trying to look at that by evaluating the racial disparity, also try to create a predictive model. So what that idea is, we should be able to predict based on some indices. So, okay, what are the previous cases of this among, in a pregnant woman, a woman, and what have been maybe, do you have high blood pressure before? Do you have any such case in your past pregnancy and stuff like that? And the third aim of this project is to train students as well. We have to make sure every other student have interest in this. Not a student start with us and stop with us. So we have to carry along other students, and that's why we focus on training. So on this particular project, we are looking at about 2.6 million natality case in US in 2022, released by the CDC, and we are looking at some of these factors. And from that 2.6 million, we have been able to reduce our data, do our data processing to 2.4 by moving individual with missing values. So, and if you look at the case, we look at gestational hypertension and pregnancy hypertension, and if you look at that, we see there is a significant increase of non-Hispanic black and the non-Hispanic Alaska Indian Native. And if you also look at this, the pregnancy hypertension, we also have significant increase in the same set of race. That's Hispanic, non-Hispanic black and non-Hispanic Alaska Indian Native. So another thing we also look at, we look at the diabetes case, and in this case, we see the same significant increase compared to other races in this same population, non-Hispanic and Alaska and non-Hispanic Asian population. And we also look at that in the pregnancy case. And these are factors that contribute to what we want to look at in this point. So what we try to do there is, we are trying to look at the correlation between pre-pregnancy hypertension, pre-pregnancy diabetes, gestational hypertension, gestational diabetes, to some of maternal outcome. Oh, okay. Is there a correlation between these cases with placenta disruption? Is there a connection between these cases with ICU admission for mothers? Is there a connection between these cases with maternal transfusion? So that's what we did in this case, and we create a correlative matrix based on our data, and we observe that there is a correlation between gestational hypertension and pregnancy hypertension that links to placenta complication. So in that case, majority of women that we look at this case, most of them that has gestational hypertension and pregnancy hypertension end up having placenta complication, and majority of them also end up in ICU. So in a nutshell, this study has underscored the intricate relationship between maternal risk factors and medical complication. And also, we propose that a future research will focus on uncovering the causal mechanism of this association and validating results in large and more diverse cohort. So what we have done in a step is to look at data released by CDC for 2023, and we're also looking at for that of 2024 for us to be able to look at the trend and to see if most of our advocacy has actually led to reduction in the prevalence of this case, and also to see if there is reduction in mortality. Thank you so much for listening.
Thank you, Dr. Adol. Our next presenter will be Dr. Jasmine Jones, who is a 2024 Doctor of Pharmacy graduate from the Texas Southern University. While in pharmacy school, she delved into research on autosomal dominant and recessive polycystic kidney disease. As a trained researcher with the All of Us research database, Dr. Jones contributed to community outreach efforts on campus to enroll more patients into the database. Additionally, Dr. Jones completed rotations with Pfizer's Global Regulatory Science Department and the FDA Office of Minority Health and Health Equity, which highlighted minority health disparities in various stages of drug development. These experiences ignited her passion for minority health research, and she looks forward to further exploring this field. Please welcome Dr. Jasmine Jones.
All right, good afternoon, everyone. I'm Jasmine Jones, a postdoctoral fellow and pharmacist in the MH REACH program under Dr. Poon and Dr. Ajawale, and I'll be discussing our project, Building an Innovative, Comprehensive, and Multi-Level Medication Therapy Management Model, or shortened for MHRX project. So the overall goal of this project is to create a medication therapy management program, or MTM for short, for Black pregnant mothers that not only addresses non-medical drivers of health, but also provides support, social support for mothers with these identified non-medical drivers of health, as well as providing remote blood pressure monitoring in hopes of identifying and reducing hypertensive disorders in pregnant Black mother in our community. In this presentation, I'll be talking more about our AIM-1 and the data we've gained from AIM-1, whereas AIM-2 will be more of the medication therapy management model. So in AIM-1, we focus on identifying and providing solutions to non-medical drivers of health. And by this, we've developed a work group of community members who are health advocates or providers in the maternal health space to identify these non-medical drivers of health that we feel are impacting our Black mothers. Our work group is entitled the Voices of Pregnant and Parenting Work Group. As you can see, we have a wide variety of providers, community health workers, and social workers. Some of them are here today, so that really shows their dedication to maternal health and improving outcomes for Black mothers. I'll be going over some summaries of our work group sessions. So the first one was just an introduction, just to introduce the project as well as go over guidelines for the work group. The second group, we identified social determinants of health, non-medical drivers of health that we felt were either positively or negatively impacting Black mothers, including topics of racial bias in medical education, and things that are working like patient-provider trust and a good patient education. Session 3, we went over specific encounters with non-medical drivers of health that they feel may be impacting maternal outcomes, like food insecurity, housing instability, and access to OB care, where we discussed programs that may help, like WIC, more community involvement, and the use of doulas or midwives in between traditional OB care. In session 4, we did more of a resource sharing. So just going over what we currently have in our community that our Black mothers can get access to right now. So our most recent sessions, which is session 5, now that we've identified these non-medical drivers of health, what can we do to implement some of these solutions that we have also identified? So creating like patient materials that covers a wide range of languages and also provides graphic like pictures so that we can make sure the patient is getting the information that they need and it reaches all literacy levels in all language, as well as providers tailoring their message based on the audience that they're seeing. In session 5, since we are hoping to develop a more pharmacy-based project, we wanted to ask like the reception of medicine being prescribed in pregnancy, where we discussed it was a big topic on medical mistrust, and that if you don't necessarily trust your provider, how willing are you going to be to take the medication? As well as some people on the call explained that we may need medication, but we're not giving them based on the perception of maybe race or socioeconomic status. And then the last session, we had a mother on the call who gave just our personal experience struggling with hypertension in pregnancy and how she felt that what was listed on her medication, her medical profile, affected her level of care, and how she feels like that's why she struggled with hypertension and she had a more traumatic birth. So just the next steps for this project. So for AIM 1, which is the Voice of the Pregnant, continuing our monthly meetings until May 2025. We like to keep collecting data on non-medical drivers of health and their solutions, as well as integrating this information into our AIM 2 of our project. And we would love to disseminate more in community engagement sessions like this one, as well as publications. And then for AIM 2, we're gonna work on training pharmacists like myself and interns in our MTM model and enrolling patients and integrating what we've learned in AIM 1 into AIM 2. Thank you.
Next, we've already did our introduction for Dr. Poon, but she is going to come up here and give us some great and valuable information. Please welcome back Dr. Poon.
Thank you. All right. So, well, this is so much information. Do you feel like so much resources and information in front of us? So hang in there. We're almost done. I'm going to make it very brief. You can think of me as, I don't know, I'm going to start calling myself the training queen, okay? So teaching, training, mentorship has been my core. And I started teaching at TSU many years ago. I'm not going to say the exact years, but that was the reason why I am at TSU, and for so long is because of the students, for the pharmacy students and faculty. So I start off with training students, and then as my career goes on, I start training faculty and postdocs, and so I'm going to be very brief and talk about what are the training activities here we have in MH Reach. So there are 3 different goals, or we call it aims, that we are trying to achieve. Number 1 is we want to develop a course that is about maternal health disparities. And then it also teaches a little bit about research. And so to inspire the next generation of students and investigators who get interested in this topic. Like what Dr. Olayeye has said, we don't have a School of Public Health in here, so we mainly trying to gear towards students who are pre-med, pharmacy, pre-pharmacy, social work, psychology, and it could be any undergraduate student, but many of them were interested and become interested in this topic. This is our goal. So number 1, we want to develop a course. And so MH Reach started like about a year ago. Yeah, so last year we have developed a variety or implement a variety of curriculum. One is we have developed an online asynchronous curriculum that has 8 lessons, and that was being tested in some high school students and pharmacy students and some health sciences students. And we did pre and post tests to see how they felt. Is it too difficult? Is it too hard? And then we kind of like try to track through them and see if it inspired them to move on in this direction in research and in their studies. So we also offer a undergraduate program training that I will go through in the next slide. So AIM 2, Goal 2, is to offer training in research and mentorship. And I'll go through some examples of research projects that our students are having. So AIM 3 is to evaluate the impact. We want to track them and then evaluate and see how is our training curriculum. Does it tailor to what they need to know, or does it inspire them in their career growth? So one example is training our undergrad student. So this slide has some pictures, and it has our flyer for our summer data analytic workshop. And that's a picture of our undergraduate student getting trained. And for this particular program, we implemented from June 2024 to March of 2025. So it's like over a period of months that they come in and train by Cecilia, and also Dr. Whitman, Scott Whitman, and to teach them about data analytic. And so at the same time, so this is a copy of the flyer for that particular training program. So the next slide should have the high school. Yes, at the same time, we have this high school maternal health summer research program. And we have successfully trained 10 high school students, and we recruit them from the Houston area high school. And all of them went through the asynchronized online training. We also at the same time trained four undergraduate students and pharmacy students. They all complete the modules, and then so they have to complete the online module first at home, and then they come in for the research part of it, that we provide mentorship, and we assign them into individual projects, and they went through about a month of time and work on the projects, and they all present at the symposium that we had in August. So the right side is a copy of the flyer that we distribute to our high school partners. And we're planning to continue with it because of the success. And I also want to, I'm a little over time. I tend to talk too much, sorry. Okay, I want to point you to the direction, like in your booklet, there is like almost the last page, there is a article that is written by our high schooler. So if you have time, read that up. Very, very proud of them. We also have research training, and these are research projects of our undergraduate students, and they did projects that are mentored by TSU faculty and also from Morgan State University, which is the HRSA Maternal Center, Research Center Coordinating Center. So some examples of the poster that is listed on here is also in the booklet, so read them up if you are interested. So I'm done, sorry, I'm over by 1 minute.
Thank you. Okay, the next person I'm bringing up is Dr. Pounds, one of the sweetest women here at Texas Southern University. She always has a warm smile and a hug for you if you need it. Dr. Pounds has over 25 years of experience developing programs that address disparities in health through community engagement and participatory methods. As a trained health educator and researcher, her work has addressed tobacco prevention and cessation, cervical and ovarian cancer survivorship, women's participation in chemo prevention trials, women's decision-making in health, and pharmacist home-based models, diabetes and hypertension management. In her current role as an associate professor in the College of Pharmacy and Health Sciences Health Administration program, she trains health professions students in development of community-based programs. Dr. Pounds also serves as co-director of the MH Reach Community Engagement Corps. Please give a round of applause for Dr. Pounds.
Good afternoon, everybody. I'm excited to be here and share with you a couple of examples on two of our maternal health initiatives here on campus of how we engage the community, which is really important to the work that we do because our community helps to inform our strategic planning on these projects. Our community keeps us informed of what's most important with the women that we're working with so that our work is relevant and timely. So our community engagement corps is made up of myself, Drs. Danae King, and Kennedy Norwood, our community health worker, who is actually manning our table right outside. So there are four approaches that we use to make sure that we are doing a good job in engaging the community. One, we involve the voices and experiences of people who not only have lived experiences in maternal health, but also those who have professional experiences, those who work in advocacy in the community, those who are just the next door neighbor that checks on the women and men in their community who are expecting. We also work on building the capacity of the community, and I'll talk about that in another slide. One of the things that we ultimately want to be able to do as the Community Engagement Corps is make sure that when we create all of this wonderful research, that it's packaged in a way that people can not only read about it in the community, but they can act on it. They can use it in their everyday lives. So that's a tall order for our Corps, but I think it's something we can certainly do with the amount of experiences that we have that the people from the community bring to the table in our Community Engagement Corps. And lastly, we always want to be evaluating what we do so we can continuously improve. This is our Community Advisory Board. They are made up of people with a wealth of experiences. We have mothers, we have clinicians, we have also clinicians, we have people from the mental health and behavioral health sector. We have Nathan Maxey, for example, that works in HIV, that has a special interest in looking at how sexually transmitted diseases are impacting our moms and what can we do about it. I'd like for any of our Community Advisory Board members who are here today to please stand so you can be recognized. We have Ms. Trina Cook, and we have Ms. Lakeisha Valier. Thank you, thank you. Another way that we want to engage the community is to build the capacity of the community. So as my colleague, Dr. Poon, talked about training, in the Community Engagement Corps, we focus on training in the community. So one of the things that we've done and that we're really proud of is that we have instituted a scholarship program for residents in the community that want to be trained as community health workers. This is a list of our current scholarship awardees, and I want to apologize. Ms. Portery is actually not Ms. Goodwater. So that's a typo. I'm sorry about that. But I'd like for our scholarship recipients to stand if they're here in the audience. Thank you, and congratulations. They will actually start their classes. We are working with the Area Health Education Centers that is located in 5th Ward, and they will start a virtual program with Area Health Education Centers starting in February. Actually, before I move on to the next slide, one of the last examples of capacity building that I want to mention is that we also have a community pilot program. And in that community pilot program, what we're going to do is provide 8 community organizations with $10,000 grants to further the work that they do. And this year, we are really excited that we have 2 programs that have been awarded. One is the Zeta Phi Beta Omicron Gamma Chapter, the Northeast Coalition for Advancement and Transformation. And they will focus on putting on educational and resource sessions for communities, specifically in Acres-Home and Sunnyside, and some of those zip codes that are greatly burdened by negative maternal health outcomes. Secondly, we have the Northeast Coalition for Advancement and Transformation. They will focus on addressing environmental factors that contribute to maternal health outcomes, particularly in the Senegas communities. So we're really excited about being able to support the work of our community organizations because they are certainly the boots on the ground. Some of the things we do here on campus, because yes, we work with the community outside of the campus, but we also have many mothers and fathers here on campus. So one of the things that we're doing is working with the Texas Southern Facilities Department to look at how we can support the rollout of the lactation rooms. This is an example of the lactation room that was actually created by Dr. O and Ms. Charlie King when she was a student. And this was our first lactation room on campus. And just a quick shout out to those other programs on campus that support our efforts and work with us. The SHAPE initiative focuses on substance use and mental health and HIV and AIDS. You're going to hear from Dr. Henderson and his colleague as they talk about the Center for Justice Research. We also have up-and-coming surveys that will be rolled out by faculty on our campus to further explore maternal health experiences. And we have the TSU Mental Health and Wellness Services that are free and available to not only students, but even the staff if they need here on campus. Save the date. April 11th through 17th is recognized nationally as Black Maternal Health Week. Last year, we had a lunch and learn that was well attended, as well as a resource fair. This year, we are doing what we think will be a bit more impactful so that students and staff here on campus who are pregnant or who have delivered within the last 2 years will be able to participate in a community baby shower here on campus. We're happy to say we will be partnering with Harris County to implement this program. If you want to learn more and keep up with the activities that we're doing, we have the QR code here, but please stop at our table when you can and sign up. Okay. Thank you. Where's the next one? Okay. So, guess what? I get to do another one. Okay? All right. You thought you were done with me. So, our Maternal and Infant Environmental Health Riskscape Research Center is also called MIEHR, M-I-E-H-R. And this is a partnership between Texas Southern and Baylor College of Medicine. And what we do is we focus on Black mothers in the U.S. and we look at different factors that impact their experiences. So this is just a scheme and a quick image of those specific factors that we look at as a center. We look at the built environment. How many people know what the built environment is? The built environment, when I usually explain it, is things that appeal to our senses. It's the air that we breathe. It's the food, the water. It is the smells that we encounter when we sometimes go into certain neighborhoods. It's also the things that we can feel or that provide shelter to us, like some people live in homes that aren't structurally sound, so they're more at risk of having issues when we have hurricanes, when we have these winter storms, when we have extreme heat episodes. And so as the climate changes, our physical environment is impacted. And also we know that here in Houston, there are concrete batches that are also causing certain risk factors for residents of those communities. That's part of our physical environment and the built environment as well. Our social environment has to do with the networks of people in our environment. It has to do with the policies that create these unjust discriminatory practices and systems, for example. The social environment is all about how connected do you feel to your community. And so these are the things that the projects of MIEHR work to understand. So these are examples of two of the projects that were produced through the center. The one on the left was a project where over 1,000 women in Houston participated and agreed to give urine samples. And the faculty member, our researcher, was able to test that urine to see, one, where do these women live, and two, what environmental contaminants are they being exposed to. The flyer on the right is a focus group that was done by our very own Dr. Danae King, Takara Taylor, and another one of our, at that time, graduate students, Myasia Taylor. They did a series of focus groups, and they wanted to explore what were the experiences of the mothers. Their research did reveal that discriminatory practices and biases in the system, just as Dr. Jones mentioned earlier, were also things that they had experienced. We couldn't do the work that we do in MIEHR, again, without our community advisory board. We have advocates who have been working in environmental health and maternal health for 50 years or more. And we are really blessed, and we feel really honored to have the opportunity to work with these individuals. If you want to learn more about MIEHR, please sign up. We send out updates about what we're doing. We send out information about activities that we'll be doing in the community. I want to do a shameless plug. We do have what we call an emergency preparedness bingo that we are happy to come out and do with groups of parents because it focuses on how to help mothers prepare for natural disasters. So if you're interested in having us come out, please stop at our MH Reach table to talk to our community health worker or go to this QR code. Thank you.
Thank you for that. The next person that we're bringing up is Dr. Howard Henderson, who is a professor of justice administration at Texas Southern University and the founding director of the Center for Justice Research, which utilizes community-level data to study criminal justice system disparities. We're also going to bring up Dr. Bourgeois. Is that how you say it? Thank you. Is a postdoctoral fellow at the Center of Justice Research at Texas Southern University, where she examines disparities within the criminal justice system at the intersection of race, class, and gender. Her research also focuses on perinatal health disparities, discretionary decision-making, and parental incarceration. Please welcome Dr. Bourgeois and Dr. Henderson.
It's afternoon now, so good afternoon. I recognize as one of the few men in the room. I'm gonna hurry up and sit down. But Dr. Olalele, thank you so much for inviting us to present our research. As she so eloquently stated, I'm Howard Henderson, professor, School of Public Affairs, but I also run the Center for Justice Research on campus, where we focus on criminology and understanding justice in our system. Jennifer, who is our postdoc, essentially a doctoral student who did a great job. You don't want to let her go. And so we're going to present very quickly our research on maternal health and criminal justice involvement. As we were engaged in conversations with faculty and scholars around the country, one of the things we realized was that you need a postdoc to go through your PowerPoint. All right. So essentially, we wanted to understand how the justice system impacted women in these spaces. We felt that this conversation could not be had because justice is all around us. And we understood that many of these women live in environments where men and women go in and out of a jail and out of prison. And we want to better understand how that affected perinatal health. So we came up with three basic aims, and I won't read this to you, but essentially we wanted to understand how structural racism in Houston and Harris County affected perinatal health, which is a very unique conversation, and we felt that we need to be a part of that conversation. If you can go forward. We have several different dimensions. We focus on the criminal justice part. How do women who live in high crime neighborhoods, how do women who live in neighborhoods where people are going to prison, going to jail, and committing violent crime, how is that impacting perinatal health? I am going to be quiet now and let Jennifer talk, but again, we wanted to make sure that we had a conversation around how the justice system's involvement affected perinatal health. But in that conversation, what we recognized was this person of color variable kept giving us problems. And, you know, I don't know about y'all, but person of color is sort of this phrase that kind of misses the mark, okay? And so what Jennifer is going to present to you is a statistical explanation of why it missed the mark. Because we felt like this is really a call to action. Person of color, it oversimplifies realities. And so Jennifer will explain to you sort of what that looks like.
Well, good afternoon, everybody. I'll stand kind of here because I'm pretty sure the computer will maybe block me. I'm a little short. But as Dr. Henderson mentioned, we had these metrics that we were looking at on this NIH grant, and specifically what we were looking at was the criminal justice metrics. And my three metrics that I was looking at was incarceration, whether or not it was jail or prison incarceration, as well as violent crime arrest. So we had a couple of different data sets that we were looking at. We had data from Houston Police Department, as well as we had data from the Harris County Clerk Office. And specifically, the variables that we originally were looking at were the 2 race variables, which were white, and then this broad aggregate level variable, person of color. And the way person of color was kind of grouped together was putting black and Hispanic individuals into one category. What I'll present next is we have a more updated chart, but this is just kind of give a little bit overview of, this is the number of arrests broken down by year and race. So those 2 last categories, Hispanic and white, let's say we have an updated chart that explains that, but what I really want to dive into is these disparity ratios. And while we realize that that person of color variable was presenting a challenge. So what this shows is black, white, Hispanic, and the person of color variable. And that very top line there is black arrest in Harris County from Houston Police Department. Or actually, this is from Harris County Clerk's Office. And what that shows is disparity ratios showing that black filing incidents or black arrests or black individuals that were charged with a violent crime. As you can see, it ranges from 2.94 to 2.64 over this span of 8 years. They were more likely to have a violent crime charge. Then if you look at the line right underneath that, there is the person of color variable, and it shows that it was 1.27 all the way down to right at 1% more likely to receive a violent crime disparity ratio. Then if you go right underneath that, the red one is Hispanic, and those shows disparity ratios of likelihood of receiving a violent crime charge. So what that means is when you solely look at the person of color disparity ratio, what it does is by grouping those 2 together, it underestimates the racial disparity for black individuals, and then it overestimates for Hispanic. So that's why we parsed it out and separated it. And that was clear for each of the criminal justice metrics that we were looking at, whether or not it was violent crime, jail, or prison incarceration. When you group black and Hispanics together in your analysis, methodologically, what it does is it kind of masks some of the disparity. So that's why it's very important, and specifically in maternal health research and just criminal justice research overall, is to separate those variables and not preferably use the person of color variable so that you can clearly see what's going on race specific. Some of the other things that we discussed as well, and this was just, future steps and all that different things, was even within groups. So this is among races, so black, white, Hispanic, but also within groups is very important to dive into that. So looking within each variable of black, white, Hispanic as well. So there's lots of next steps that's going to happen with this particular study, looking at other structural racism variables, environmental factors, things like that. So this was just kind of the initial preliminary stage that we realized looking at that person of color or aggregate grouping variable is very, very key to separate that variable out. And I'll hand it back over to Dr. Henderson to kind of close out.
Yeah, there's nothing else I have to say other than, at the end of the day, I think it's important to disaggregate race. And anytime you see that aggregated, you have to ask the question of who is really being affected and how. And so if you start out with biased data from the beginning, then you end up with biased data in your results. And so as you clearly see here, I think for us, this is sort of like one of the most important visuals because you clearly see at the very top, that's the reality of black prison incarceration in Harris County. And at the very bottom, you see the Hispanic group. And if we were going with person of color, you'd see it be the blue line. And so you'd miss them. You'd overestimate the reality of justice in this community around Hispanics, and you underestimate it for blacks if you did that. And so this is more so a cautionary tale to be very careful when you see the person of color measure. It doesn't mean we can't work together, but it also means we need to understand the realities and the subtle nuances within each cultural group. Thank you so much.
Thank you so much. Wow, that was eye-opening for me. Definitely. We are going to bring back Dr. Olaleye to give us some more great information. Your closing.
I think my closing remarks is let's get to work. Thank you all so much for your contributions. Thank you for coming. I've told Dr. Ajewale that the next conference, we hope to actually go into the community and be in the middle of the community to have this conference so they don't have to travel, you know. And now TSU has a mobile van. We can take it all across Texas. But just, I don't want to take your time, be in between you and your lunch, but thank you all so much. Thank you to TSU's leadership. Give it up for my boss, BP Penn Marshall, and President Crawford for giving us, they've created an environment for us to be able to excel. And like my boss, she rolls up her sleeves and gets things done and helps us to move the needle. So thank you all for coming. And Dr. Ajewale, I cannot be more proud of you. Thank you so much for what you're doing.
Thank you very much, Dr. Olaleye. And a big thank you to each and every one. I look at the time, look at the room. We still have about the same number of audience that we started with, and maybe even a little bit more, right? I mean, give it up for yourself, guys. Thank you, thank you, thank you. And I will be remiss if I don't acknowledge the men in this room. Please. Yes, Dr. Anderson, for every man. Thank you for standing with us, standing by us, staying with us at the bedside. Some of us, Dr. Kende was saying that he slept in the hospital for like 7 days with his wife. Oh, my God. Thank you so, so very much for all the support, and we are just incredibly grateful. For those watching us online, thank you again. I'm just going to go over a couple of announcements. We can't overstate this. Please complete our survey. We are grant funded. Your feedback is very, very important to us. We will be submitting our grant report in a few months. So please scan the QR code if you prefer to do paper survey. We have paper surveys available. Amazing Brittany is over there if you would like to do a paper survey, but the preference will be for you to do it online and save the trees and use technology, right? Like Dr. Ogo said. So please, thank you. And for CHWs, don't forget to complete your evaluation as well as your sign-in, especially those that are online. Do that so that we'll be able to issue your CHW credits to you. Who would like to have this again next year? Right? Bigger and better. We are always, envisioning and dreaming and, saying things into reality. So please save the date. By God's grace, we will have this event again, 4th Annual Maternal Child Health Conference. It's going to be on Friday, January 23rd, 2026. And like you heard Dr. Olaleye said, it's going to be outside of TSU walls this time. Okay? So please save the date. More information will come, and we hope there will not be snow day. And speaking of the snow, actually, I would also want to appreciate the community centers. So we had reservation of almost 50 community individuals that were going to bus over, but because of the snow day, everything was canceled. Even though they were not able to make it, some of them are probably watching online, and to the coordinators, Virgil, working very closely with those individuals. Many thanks to you all. If you are online or anytime you watch this on YouTube, we are very grateful for your support, and we hope you can join us in our future events. Well, we stay very busy doing great things here at TSU. These flyers should be in your folders, but I want to point your attention to a couple of upcoming events. We have another NCI-funded grant focusing on cancer education and research. We will be having our webinar on Wednesday, February 12th. It's going to be in the evening. You can be fixing dinner, picking up the babies at the school, and still listen in to how you can reduce your risk for cancers. Not only are we talking about this in February, we also have another webinar and another event, actually, which will be in person as well as online. This is going to be on Tuesday, February 18th. This is where we're going to talk about chronic kidney diseases. Chronic kidney diseases is also another major disease that we see in our community. A lot of people are on dialysis. A lot of people are awaiting kidney transplant. A lot of people that get transplant cannot keep the transplant. So we just have a lot of disparities, regarding chronic kidney diseases. We are working alongside Houston Methodist Hospital, alongside National Kidney Foundation, as well as Precinct 2 to be able to host this event. So if you're available, join us in person or online on Tuesday, February 18th, 2025. Then my passion for breast cancer, again, we weave it into everything that we do. Next week, we would have a webinar on breast cancer. We titled that Impact Her. This is in collaboration with another entity called Survive Her. We're bringing in speakers, panelists. This is going to be exclusively online. So please scan the QR code on Wednesday, Lunch and Learn from 12 to 1, and we'll be providing $20 code for lunch. Lunch will be provided through Postmates. So join us, complete the survey, and you would have access to great information as well as a $20 gift card. All right. When I did the opening session, I mentioned that we are very much involved in clinical research and engagement. In April, save the date again, we will be gathered here in the same room. Right? You know how to pack, you know how finding your way here. So I hope to see you all and many more faces where we will be talking exclusively about clinical research and engagement. We have an amazing panelist of people that have participated in clinical research before. They will tell us about their experiences. We have people that are developing and designing clinical trials. And like I mentioned earlier, we are establishing a clinical research site here at TSU. So you are going to listen to the positive disruption that we're undertaking within our system to establish this clinical research initiative here at Texas Southern University. Not only that, we are opening up a clinical research registry, the first of its kind here at TSU. So we are, all hands on deck pushing towards that. That registry will be opened come April, and you would have an opportunity to sign up and be part of the change regarding clinical research participation in the community. Okay, I cannot end today's session without a big thank you to everyone that has supported us, vendors, sponsors, partners, and please help me to appreciate our amazing speakers and panelists. Oh, wow. Wealth of knowledge, wealth of information. And I know we did share a lot of information, but the good thing is we will use technology to our advantage, okay? We will use it to our advantage. All of this is on YouTube. Houston traffic is real. When you are driving, plug in on YouTube, listen to this information so that we can lead the change in our community. But a big thank you and a big shout out to all our sponsors. We do have several mobile units out on the Tiger Walk area, so please feel free to stop by there too and experience some of the clinical services that is being provided. Additionally, a big thank you to all our program staff. Please help me to appreciate and acknowledge them again, Dr. Ogbo, Jasmine, Virgil, Mark, wherever you guys are. I appreciate you. Thank you for all that you do. And to all the diverse departments here in TSU, from the Office of the President to the Provost Office, DRI, marketing, all the different places that we collaborate with to make this successful. Our interns and volunteers. Do you think we can do this alone? We cannot. So big thank you to all of them. And I'm very grateful they're all out there, serving and ensuring that today's event is going smoothly. And to the media team, Constellation X, thank you for keeping us online, doing great work. We are just very grateful to you and to the service that you provide. Another reminder about the survey. Sorry, I said over and over again because it is really important. And now I want to point your attention. This is actually at the back of your booklet. So this is where we have all the vendors, some of them here in the hallway, some of them in the Tiger Walk. Please feel free to stop by and engage with them and receive all these clinical services at no cost. I want to say a big thank you Right now, we will transition out into lunch, and at 1:15, maybe 1:20, 1:25, okay, 1:25, we will begin our health provider panel discussion. So I want to see the same amazing faces that were in this room, if you're able to stay for the second session right after lunch. So please feel free, enjoy lunch, and we'll see you soon. Thank you.
Texas Southern University. Thank you so much for taking time to join us for today's program. You could have been doing so many other things today, but you chose to make time to join us for today's program, where we will be focusing on maternal and child health outcome in our community. Sit back, relax, enjoy the amazing presentations that will be coming from our speakers, experts, panelists, and also remember to stop by and visit with our vendors and exhibitors. There's a lot of great information that will be shared today, so I look forward to an amazing conference today alongside with each of you. Thank you again, and see you around.
don't need to be on camera. Well, I'm doing a presentation too, so I do need to. I mean, it'll be weird if I wasn't on camera. So just introduce yourself and then instructions. They don't have to stand because the cameras are at a low vantage point, so they can just introduce themselves. Yeah. So yeah. So they don't have to like stand, turn around. Because this is initially we're gonna do, but just stand. Look at the cameras. They switch the cameras. But yeah. Well, you can watch me in prayers. It feels yeah. So just introduce yourself.
This is the layout I have. Just introduction, name, then introduce you, then go into questions. Thank you.
Hello, my name is Veronica. I am the Director for the Community Engagement Core here at Texas Southern University. Thank you so much for taking time to join us for today's program. You could have been doing so many other things today, but you chose to make time to join us for today's program, where we will be focusing on maternal and child health outcome in our community. Sit back, relax, enjoy the amazing presentations that will be coming from our speakers, experts, panelists, and also remember to stop by and visit with our vendors and exhibitors. There's a lot of great information that will be shared today, so I look forward to an amazing conference today alongside with each of you. Thank you again and see you around. The main purpose of our Center for Biomedical and Minority Health Research is to address the existing disparities and inequities in healthcare, especially among our underrepresented minority populations here in the United States, and more specifically for us in Harris County and Greater Houston area. We have several research areas here, and my lab mainly focuses on maternal health and child health research in terms of epidemiology work, looking again to close those gaps in health disparities here in our greater Houston area and Harris County. The other type of research that I do is drug discovery and development research, where we look for new medicines for specific infectious diseases. For example, with the outbreak of the recent COVID-19, SARS-CoV-2 that led to the COVID-19 pandemic, our lab is looking at repurposing some clinically approved drugs to work with the FDA to push some of those to be repurposed for the treatment of COVID-19.
My research is rooted in Texas Southern University and the community around that. So with that, I focus on disease such as cancer, infectious disease, diabetes, etc., and most of them disproportionately impact the minority. And for example, prostate cancer and breast cancer are the two major focus of my research. And they have obvious disparity for African Americans, men or women. So with that, with our nano formulated drugs, we're trying to reduce the disparity and improve the patient compliance. Recently, our work has been recognized as a National Cancer Institute, which is part of NIH. We become one of their subcontractors for preclinical drug development. There total 19 institutes get that subcontract, and we're the only one from Texas, and we're the only one, the only HBCU get that contract. So I consider that's a great recognition of our work.
Our research is very unique, and we are in the area of gapping the drug discovery toward actual marketing of a drug product. So our facility is very unique, at least in the Texas Medical Center area here, as well as in the state of Texas. That's why we have the CPRIT funding to support our center to provide this type of service. And we have gained a lot of experience as well as a lot of collaborations with investigators across the Texas Medical Center and the state of Texas.
When it comes to disparities in maternal mortality, our country nationally, the United States, is doing really poorly compared to other developed countries. So the work we do is very key in addressing the underlying causes and looking at the root causes of those disparities and poor maternal health outcomes. And so that's what our lab does. We work with a huge center. We just received a huge funding from Health Research Services and Administration to address and improve maternal health in the Harris County and Greater Houston area.
One of the ways that we've seen kind of real-world engagement and impact is through a collaborative that has been born out of the Community Engagement Corps in a partnership with the Gulf Coast Consortia to develop a community-engaged healthcare educational program. So it's really been exciting to provide this educational opportunity where the community is educating our clinicians and our researchers in how to do this better, and how to develop and deploy, make available important life-saving interventions and technologies.
For me, it's all about watching the light bulb turn on, the fire get lit again or rekindled in our participants' eyes. And that's been the huge payoff for me, to see faculty come into being, become more excellent at what they're doing, to see the energy come back again, and it spills out into the students. They're happier people. It was just very rewarding.
CPRIT stands for Cancer Prevention Research Institute of Texas, and within the name itself, it is cancer prevention. So we applied for this funding mechanism under the prevention pillar of CPRIT, which positions us or allows us to be able to offer mammogram at no cost to uninsured and underinsured women. So with that, we are addressing a major barrier for that population. The fact that we're able to provide services that is a bit more convenient, accessible, and specifically at no cost to uninsured, underinsured women is a big, it's a big priority for CPRIT, and we are very grateful to have been able to receive that.
One of the great things that are coming next in the future and that we're working on because we like to think ahead and work ahead is that the university has deployed a lot of infrastructure for artificial intelligence when it comes to artificial intelligence, the marriage between artificial intelligence and social determinants of health. So our core facilities here at Texas Southern University, we've deployed a lot of infrastructure, resources, and capacity into studying the role of artificial intelligence in addressing a lot of these disparities within maternal health and even using artificial intelligence for drug discovery and development. We hope that in the future with all our work, we hope to see that the synergy of working together with the key stakeholders will really move the needle when it comes to reducing breast cancer health disparities within our community that we serve.
I remember this young lady, she had just gotten vaccinated. She's African American, and she goes home and she talks to her grandmother. Grandma, you need to be vaccinated. Grandma says, absolutely not. I don't trust the healthcare system. I don't trust any of these people. I'm not going to get vaccinated. The young lady says, well, Mom, the lady who vaccinated me is African American. She says, well, in that case, take me, I want to get vaccinated. The message is important, but so is the messenger.
Data and science and study have shown that African American individuals are much less likely to be enrolled into a clinical trial. So the EQB Med initiative is going to address this major and critical problem in our community. EQB Med initiative positions us at Texas Southern University to actually have access to innovative and breakthrough clinical studies. We do a lot of work to increase awareness about clinical research participation, but without an opportunity to actually open access for individuals to participate and to build trust in clinical trial process, we are very limited.
Pharmacy is a very important team in communication with the community. And we are not only have a PharmD program, we also have a PhD program. With that, we have more outreach to the community.
We are the #1 producers of African American pharmacists in the state of Texas. Pharmacists are a significant part of the healthcare team. They're able to immunize patients. They're able to help them in a variety of health settings per se.
TSU had the RCMI support back in 1980s, especially in terms of research infrastructure. So the students and scientists can conduct most cutting edge of research, especially in the area of drug discovery and development.
In 2024, the College of Pharmacy and Health Sciences celebrated its existence of over 70 years. We lead a lot of initiatives advancing health equity, training community health workers, providing continuing education for community health workers as well as for our pharmacy and health administration students. In this initiative, we are going to partner with UTMB, Yale University, and Morehouse School of Medicine. We will be able to gain more experience and resources and guidance on how to recruit for clinical trial and how to conduct clinical trials. So this clinical research initiative under the EQB Med funding mechanism allows us not just to provide opportunities for clinical trial participation for community members, but it creates a platform for us to train the next generation of pharmacists that will be culturally competent, that will have an high level of awareness of engaging with community members to promote the concept of diversity and equal representation in clinical research participation.
Good afternoon, everybody. I'm Kennedy Norwood, a community health worker with MH Reach, and welcome to today's Maternal and Child Health Provider Session. Today, we're here to have an open dialogue amongst healthcare providers to identify challenges, share best practices, and collaboratively brainstorm solutions to improve maternal health outcomes, especially for our marginalized communities. Please allow me to introduce today's roundtable participants. Today we have William Lyons from Legacy Community Health, Donistel Fodibu from Harris County Public Health, Pamela Behrens from Harris Health, LBJ, Renee Eddings from Harris Health System, Monique Mason Rhodes from Harris Health System, Jocelyn Tinsley Greenlee from Harris Health System, Tamika Cross from Opulence Health and Wellness, Kathleen L. Vincent from UTMB, and Lakeisha Booker from Baylor Teen Health Clinic. Okay, so before we go into our discussion, I'd like to introduce Dr. Jasmine Jones.
Good afternoon, everyone. I'm Dr. Jasmine Jones. I'm a postdoctoral fellow and a pharmacist here in the MH Reach program. Most of the panel should know me, so I sent those annoying weekly emails every week, every on the dot. I send a ton of them. Everyone I CC'd knows I sent those annoying emails, but I'm very glad to see everyone here, to see you in person. I've seen your bios and headshots like every single day for like the past 3 months, so it's very exciting to see everyone in person, and we're very thankful that you are here to support TSU's efforts to reducing maternal mortality, specifically in Black women. So before we get into the panel discussion, we wanted to just explain to you why we want to create a toolkit and cultural competency for providers, for you guys. We want to distribute something that will just provide value and for our Black mothers, for mothers of color, that you guys can use in your practice. The MH Reach program wants to reduce maternal mortality in Texas. That's our biggest goal. So in doing that, we wanted to look into states that had lower maternal mortality rates to see what they're doing and what they're successful in and how we can implement them here in the MH Reach program and eventually throughout Texas. So in doing that, we noticed that California had a lower maternal mortality rate, and Dr. O assigned me to research this because I'm originally born and raised in California. So this is very near and dear to my heart. Like my grandmother gave birth in California, my mom gave birth in California. So this, as we've seen with data, with Black women, no matter, this is very important to Black women in my family. So that's why we looked into California. So in this presentation, we're gonna highlight the overarching theme of the maternal and child health in California. This is gonna be the Maternal, Child, and Adolescent Health Division, which is under the California Department of Public Health, and they oversee and regulate maternal and child and adolescent health programs within California. So they are like the big department, and then each county level will have their own maternal, child, and adolescent health. So within the Maternal, Child, and Adolescent Health Division, they have several programs to help for child and maternal health. But I've highlighted 4 that we felt were the most relevant to our research and that have a common theme and what kind of led us to wanting to develop a toolkit. So these 4 programs are the Black Infant Health Program, Comprehensive Perinatal Service Program, Perinatal Equity Initiative, and California Maternal Quality Care Collaborative. As I go through these programs, I want you to kind of recognize the common theme that these programs have. So that's kind of one of our driving factors into why we wanted to create these toolkits. So the first one is the Black Infant Health Initiative, which in California was birthed after they noticed that their maternal mortality rate was going down. But as they were noticing that, they saw that there was an increase in Black infant mortality. They noticed that their Black infants were 2 to 4 times more likely to die than their white counterparts. So they said, what can we do to make sure that our Black infants aren't dying? So they created a program called the Black Infant Health, which is a program within most of their counties' health department in their maternal, child, and adolescence programs. And it provides individual and group support to pregnant and postpartum Black women and birthing people, with aims to recognize the role anti-racism, social and economic stress, and neighborhood conditions play in poor birth outcomes for Black patients. And this is offered to pregnant women at least 16 years of age, from pregnancy up to 6 months postpartum, and it's a free service. The next one is the Perinatal Equity Initiative, which was designed to address racial disparities in infant mortality by providing support and resources to Black families. This is a program under the Black Infant Initiative, and it wants to reduce maternal and improve mortality and improve outcomes for Black infants. And this one, it's really targeting Black families and providing resources that parents in Black families and Black infants need to thrive. So not only providing support during pregnancy, but they're providing postpartum, before conception as well, and also providing resources to fathers and other parents in the child's life. The next program is the Comprehensive Perinatal Service Program, which is a Medi-Cal program, which Medi-Cal is just California's Medicaid. So it's offered to Medi-Cal patients to provide a wide range of culturally competent services to pregnant individuals, like OB care, psychosocial care, health education, and it just requires them to be a Medicare patient, a Medi-Cal patient. And the next one is the Maternal Quality Care Collaborative. This was one of the driving forces on why we wanted to develop a toolkit for, as we'll go into, we'll see how they are really impacting maternal mortality. So they were funded in 2006 with the mission of ending preventable morbidity, mortality, and racial disparities in maternal care. And they do this they have a data center, which they have over 200 hospitals that collaborate in that data center. And basically the data center, they link OB care throughout the pregnant woman's care, like progression through care, with a birth certificate so they can track it all the way from beginning to end, and that's what they have in the data center. And then they have quality improvement initiatives as well as research to improve outcomes for mothers and infants. And since the start of this initiative, California has seen a maternal mortality decline of 65% between 2006 and 2016. So as you can see, it's a very efficacious program. So a little more into their quality improvement initiatives, and this specifically is what drew us to this program, is that they develop evidence-based quality improvement toolkits in leading causes of preventable deaths and complications in mothers. And then they engage hospital systems with these toolkits to implement them with their providers, in addition to their data center as well. So using the data center and then creating these toolkits, as well as like having them in the hospitals for providers to use. And just a little more into their toolkits. They aim to improve healthcare response to leading causes of preventable death among pregnant and postpartum women. and reduce the harm of infants and women for overuse of OB procedures. So all toolkits, they provide, it's like a collection of articles and best practice guidelines that these providers in these hospitals can use on preventable causes of maternal mortality or morbidity. And they create these toolkits by engaging with experts in the maternal health space around California. So that's what we wanted to do here, is to get people who work in this space who can tell us what our patients need, so then we can create a toolkit to put in our hospitals for their use. So what is working in California? We noticed that providing cultural competent resources to Black families is what is working in California, as well as partnering with specialists in the maternal space in California to produce evidence-based toolkits for providers to prevent preventable maternal deaths. So with that being said, we thought it would be a great idea to put the two together. If we're putting resources, culturally competent resources for Black families, and we're creating these evidence-based toolkits for providers, why can't we put that together to give a culturally competent toolkit that our providers here in Texas can use to hopefully reduce the maternal mortality rate here in Texas? So that's just my brief presentation of our driving force, and we're hoping that the information we gain here from you guys can help us create an effective toolkit for our providers. Thank you. I'm going to bring Kennedy back up to the stage.
Okay, so before we go into the questions, I'd like to start with brief introductions for our roundtable participants. Do we have microphones? Okay, so whoever would like to start first, just brief introductions, please, with your name, your profession, and your main demographic that you care for.
Okay. Oh, great. So I'm William Lyons. I am a social worker by training. I work at Legacy Community Health. At Legacy, we support both maternal and pediatric health from the start of the pregnancy all the way to that child is born and beyond. My particular role is working on social drivers of health, so we support our patient population with being sure they have access to basic needs like food, affordable housing, transportation to get to and from their medical visits.
Can y'all? Okay. Good afternoon, everyone. My name is Donna Stell. I am an internationally board-certified lactation consultant, and I have the privilege of working with the Harris County Public Health Department, the Maternal and Child Health Program. My passion for maternal health really goes back to my mom. I was in a breastfeeding study, which we think is kind of ironic now. Also, I'm a mother to a preemie warrior as well, and I've had to walk that NICU journey, and I'm just really honored to be here and be on this panel to, like you said, put these ideas together and see what we can really do to go out into our communities and make a difference.
Good afternoon, everyone. My name is Renee Eddings. I am a registered nurse. I'm a director of labor and delivery at Ben Taub. And our patient demographic that we primarily serve is Hispanic and African American. And my passion for maternal health is our patients are my sisters, they're my cousins, they're me. So what can we do to put things into place, evidence-based practices into place to ensure that they're gonna walk out of the hospital with their babies healthy and thriving, so.
Good afternoon. My name is Lakeisha Booker. I'm a registered nurse for Baylor Teen Clinic. I am the supervisor for Nurse Family Partnership. You all may have heard of Nurse Family Partnership. We are one of 4 sites in Houston. We serve moms that are pregnant with their first baby. They enroll in our program before 29 weeks of pregnancy, and they stay with us until the child turns 2 years old. So it's about a 2.5-year program. We serve mainly African Americans. However, we do have other races in the program. My passion for maternal health goes back to I had my first child as a teen, and of course, this program wasn't available then. It's been in Houston since 2008. It's been around for over 50 years. But I would think, that if I was able to be a part of this program, I've done well in life, don't get me wrong, but I think that I could have done better things as far as being a mother. And so I'm able to give back to the community, mainly now with the nurses that I supervise, but I was once a nurse home visitor as well. It was very fulfilling.
Good afternoon. My name is Jocelyn Greeley. I am an OBGYN physician. I say that I have the best job ever because I not only get to work in the Harris Health System with a lot of the people here in Sunnyside at the Martin Luther King Jr. Health Center, but I also work for Baylor College of Medicine. And so a good part of my role is educating medical students and residents in the OBGYN department on how to be better providers, be more community focused, and all of the inclusivity and initiatives that we're talking about here today. I guess my goal or my excitement for maternal health came once I decided to be an OBGYN. But I think that one of the things that we have been trying to do, but this initiative here today looks like we're going to move the needle forward, is actually bringing the clinicians outside of the hospital and working with members of our community and actually making the impact. And then I think the other thing that I want to make sure that we do is how do we get the information to the individuals on the ground? Because I feel like if I had a penny or a dollar for every patient that said, I wish I had known that I could come here for my prenatal care, I would have come 3 months ago or 2 months ago, or that I didn't need to have my Medicaid already, or that I could have been seen. And I just feel like for some reason we're not getting the information to the individuals that they know that they can be seen and get started in care, and that there are all these resources there for them. And how can we put that all together and put it in a digital space or wherever so that they can push a button and say, I can go here, I can go here, I can do that. And these people will actually welcome me and take care of me in a positive way. So congratulations to all you guys are doing.
I don't know, I can't get it working. Hi, I'm Pamela Behrens. Similar to Dr. Greeley, I am an OBGYN working in Harris County. I'm kind of the LBJ counterpart, I guess I would say, and my background is through UT. And I agree completely that early access to prenatal care is something that we struggle with regularly with our population. They just don't know how to do it, don't know where to go to get help. And so I thank you very much for inviting me here. My other hat and my passion is also lactation. I also happen to be a lactation consultant. So again, another area we can do better. So thanks.
Hello, everyone. My name is Monique Mason Rhodes. I am a nurse for a long time in OB. I'm the director of nursing over at Harris Health at Ben Taub, and I'm also a doula, a practicing doula. So my passion, and I think everybody who works with me know it is access to patients being able to be autonomous on where they want to deliver, what type of provider they want to deliver with, and be able to get Texas to at least, how can I say this, begin to reimburse or at least cover doula services for our patients. So thank you.
Hello, I'm Kathy Vincent. I am an OBGYN as well. I work at UTMB in Galveston, and I started working with our colleagues at TSU through a translational science grant that we have put in together and looks like we'll be getting that soon. And so my major focus has been on research in women's health, which has, over the past couple years, moved towards maternal health and mortality, and also racial disparities related to maternal mortality, morbidity, endometrial cancer, things like that. I work with a lot of medical students on their projects. And what you guys were talking about, the California, my students had looked into something like that as well. And we should get together because I love what you added to that. My students also looked at 20 different states altogether, like the best and the worst, and kind of what, it's kind of like the show What Not to Wear, like what to do, what not to do. And like what Texas has already started doing, like understanding that. And so I think I see my role as having worked with residents in labor and delivery. I don't do that anymore, but just kind of from the research point of view, how can we take what we understand and what we know and kind of help organize that to create these strategies, understand, and then be able to disseminate, and then use our resources like the Translational Science Award, everybody's experiences to kind of create an output and a product that is going to work, and then using our research experience, be able to kind of evaluate that and continually improve that. So I'm glad to be here. Thanks for inviting me.
Good afternoon. My name is Dr. Tamika Cross. I am a board-certified OBGYN. I am currently in private practice at Opulence Health and Wellness out in Pearland. I used to work at UT McGovern Medical School as assistant professor for 3 years after training there, specifically at LBJ. So I've always had a passion for maternal health and the different health disparities that I saw firsthand. I always tell patients, like, yes, I'm a doctor. I was a Black woman before I ever became a doctor, so I definitely understand both sides of it. I also am a mother to, I had a 35-weeker. I had severe preeclampsia, so I also have a different perspective now after going through that on what patients actually experience after treating hundreds and hundreds of patients with preeclampsia and premature babies going to the NICU and things like that. So very passionate about Black maternal health specifically. I do a lot of talks from coast to coast about implicit bias and how us as providers providing culturally competent care and how we can remove systemic racism from the provider aspect and how that impacts the way that we treat our patients. And so very happy to be here, very honored to be here, and I appreciate you guys for having this.
Okay, thank you so much for all being here, for taking time out of your day to be here. We truly appreciate it. Thank you so much. So our first question today has a kind of little icebreaker is, how do you tackle implicit bias in your practice? Whoever wants to go first. Go ahead.
I will go ahead and speak to that. As an IBCLC, there are less than 2%, I believe, of Black IBCLCs. It is a very vigorous process. It is a very expensive process to get certified. There is a wealth of talent that is out there that just can't get to the next step. Some of the barriers that I experienced along my journey and some of my cohorts have experienced is when we get to that point where we need a mentor, where we need to clock on-hand clinical hours, we can't find anyone. No one has time. No one has the resources. They want to contract you to work for them at very low pay rates, but they don't want to help you excel in the field. That bias in itself hurts mothers and babies, especially our dyads that want to provide breast milk for their babies, for our NICU parents who breast milk is honestly the better option for them. So from a career standpoint, the implicit bias comes down to basically not thinking that as a young Black woman, I'm qualified, that I have the credentials, that I've gone and done the studying, done the work, and things like that. And on that aspect, it was literally just a push through. I was blessed enough to be in a hospital at LBJ to where I was surrounded by staff that really pushed me and encouraged me to start this journey. And so I was able to utilize that space and gain those clinical hours and things like that. But there's a wealth of talent who they're not in a clinical setting. So when it comes to them needing that extra time in those spaces, it's very, very hard to come by. As far as in the practice realm, it's interesting when you walk into a space and you say, hey, I'm the lactation consultant, I'm here to help with breastfeeding. I've gotten responses all the way from, I'm not doing that. It's stressful, it's depressing, it hurts. And that's not always coming from the mother or the birthing person. A lot of times that may be coming from the nurse, that may be coming from the OB, that may be coming from the pediatrician. And so with those experiences, I've learned that when it's applicable to have a conversation and say, hey, do you know what a lactation consultant is? Do you know what we have to do in order to be certified? These are the ways that I can help you. These are the ways that I can help your patients, your moms, your babies, your families. And a lot of times, that's when the light bulb clicks. It's like, oh, you're not here to hurt these people. You're not here to be the breastfeeding Nazi and keep them from bottle feeding, and things like that. You're there to educate, inform, and assist. And so I think what this space is doing and what a lot of these spaces are doing is allowing the conversation, the introductions, and the continuity of care. We can have an OB, we can have a doula, we can have a midwife, we can have a lactation consultant. To me, that's the dream. That's the dream birthing team, right? And so I think in addressing implicit bias and the structural racism that exists in our healthcare system, we do also have to kind of check ourselves in our approach when we're encountering people who may be in a different field or a different realm of practice in maternal health care.
I was just going to say, for me, as a clinician that works in a medical school, one of the things that we encounter often historically with the ways that things structurally were done in our public healthcare systems is things were different at Jeff Davis and other hospitals than other private hospitals. And one of the ways that we try to counteract the biases is making sure that our students and residents who are coming through, make sure that we have them behave and interact with patients the same way, no matter what system they are working. And so you will see oftentimes students say, oh, well, we can do this at Bentab, but we can't do this at this hospital. No, you can't do that here either. It's the same. The people are the same, the care is the same, and making sure that we continue to educate and enforce that even though our patients that do come to our public health care settings may be more permissible and more grateful for the care, they still have the same concerns, thoughts, ideas, and rights as everyone else. And I think that as in medical training and medical schools that we have to make sure that we continue to enforce and make sure that everyone is respecting that equally across all systems.
I guess when I think about implicit bias, I think about being a nurse and also trying to bring our community together with our healthcare providers. I think that's very important when you're thinking about, like I said, my passion of having doulas working. And like you're saying, this is the perinatal team. So the team is everybody that interacts with her. And so I think one of the ways that we could do it is continuously trying to do things like this, where we're bringing the community and healthcare providers, whether they're nurses, whether they're physicians, whether they're midwives, together so that we can understand one another. One of the biggest problems with bias is that we don't get to know each other. And we continue to bring on all our social stereotypes of each other before we even get to know that we are all human. And so I think the biggest part is bringing the community, bringing providers together, and everybody kind of joining in and saying we're all here for the same thing. And that's my biggest thing with that.
I just wanted to speak about that as well. So regarding what we're doing, I think it's important that as community leaders, that when we identify a problem, that we are part of the solution. And so implicit bias is something I've talked about for years, and going to different spaces. And so now, as one of the medical directors in the Memorial Hermann system, I actually gave the inaugural required implicit bias training for physicians last year. And so what I do in my implicit bias training, I always start off with doing an exercise just to identify that we all have bias. Right? Every single one of us has a bias, whether it's race, gender, background, socioeconomic status, we all have bias, and it's important for us to identify that and recognize that, and then to work around how we can overcome that, because it definitely is going to impact the way that we treat our patients if we are already having these preconceived notions about them before they've even opened their mouth. They walk in, they're late for their appointment. Why are you late? Why are you late? Like, first of all, I think it's important for us to give grace to patients and understand their background and what it took. They hopped on 3 buses to get to that appointment, or and just recognizing those things. Or somebody hasn't come to a OB visit in a while, and what I've seen in some of the hospital systems, and it's like, okay, well, did you do a drug test on her? So she's a drug addict because she didn't come to her appointment on time. So it's just like a lot of these things that I feel like we need to change the narrative, and that's something that always irritated me as a person of color through training. And so now how I'm implementing that, besides doing the implicit bias training for other physicians, is recognizing my own bias, because there's moments where I'm just kind of like, no, come on, And so you have your moments, but you have to learn how to overcome them and recognize them and do it regularly. You can't just do one implicit bias training and that be good for the rest of your career. It's something that needs to happen frequently, whether it's twice a year or annually. And so I think that we all need to do that as community leaders in general.
Yes, thank you so much for that input. So the next question is, what barriers or policies have you seen or faced that impact patients negatively or positively? How have these barriers shaped your approach to care?
Well, I think one thing that's coming on the horizon is more universal screening for social drivers of health. So with the state kind of pushing it and mandating for managed care organizations to do that screening, it's consequently forcing hospitals and clinics to also screen. And so I think we have a better opportunity to identify inequity and insecurities to be able to address that with our patient population, versus having someone leave with a prescription but then not having a way of paying for said prescription. Someone scheduled for an appointment and they literally would be either driving an hour to get to that appointment, given that many of the obstetrics clinics are shrinking, becoming more centralized. People are traveling further to get to the clinics, meaning that I have to account for more drive time for a 15-minute appointment, mind you. So just recognizing that, I think with that universal screening, we'll be able to really know more about our patients to better support all their needs versus just their medical needs.
Just related to that, I think that's a really good point, and it's an important first step. And when we talk about social determinants of health, it's just like a word or SDOH. But when you really kind of unpack that and talk about how do you implement that, I mean, I have a grad student working with me on that, and it is just hours and hours of discussion. Say it's like, first of all, what questions are you going to ask? Are you going to use Prepare? Well, we have Epic. So ours is like, it shows up, it's a pop-up screen, but then when we write the patient's note, only tobacco will show up in it. So then we actually found out that we ask every patient that, but then it doesn't actually show up in the chart where we can access that. And so then after that, well, we're asking, but then, we can get into this app called Find Help. But then most of the resources, and this is Galveston County, or we have an Angleton clinic as well, and hospital in Angleton. But then when you actually try to get help, many of the resources, they don't answer the phone or things have changed. And I just want to give shout out to Harris County and Houston, like health districts. And when I was at the meeting in October, you guys have amazing resources, and I want Galveston County to be like you. And so I think you guys really are way ahead of us. So I'm not saying that's in Houston or in Harris County, but in Galveston, that's a major problem we have. And I think that a lot of providers don't want to ask a patient about food insecurity if then the patient's like, yeah, I have that. And then I'm like, okay, well, here's this number, but when people call it, nobody answers. Like, how do you even, where do you go from there? So we need to ask, but then we need to have the resources, and that's where we get really stuck.
One of the barriers that we had in Nurse Family Partnership was the postpartum mom being able to carry on with insurance after she gave birth. And so, initially I believe it was 30 days and then she was cut off. Well, in 30 days, if she hasn't gotten her, first visit with the doctor after she had the baby, the doctor had too many appointments or whatever the case may be, then it's cut off and now she can't go at all. And so with the extension to 12 months, it has helped our moms be able to get on birth control because, one of the goals that we have is to prevent subsequent pregnancies. And they're able to, if they're experiencing something like postpartum depression, they can go and get the services that they need for that. And so that's a barrier that we were able to overcome for now. We're hoping that it'll stay that way.
Yeah, Legacy was able to implement a postpartum access to therapy program with the extension of Medicaid to 12 months. We were able to implement a program where we're addressing depression, anxiety with 12 consecutive CBT sessions for moms who screen positive for postpartum.
Oh, I was just going to say a barrier that I still see, even though we have all these wonderful programs, I still see a barrier in the patient's ability to do what it takes to get enrolled in these things. And I think that, again, early prenatal care is super important. We know, especially for hypertension and prevention of preeclampsia, that these things make a difference, but yet she's overwhelmed. She has 2 other children and no significant other, and she's pregnant, and we expect her to be able to submit all the required paperwork. Is just overwhelming. And I think that that's still a barrier that we need to work on, even though the programs are there, helping her to be able to do what's required to enroll in the program quickly and easily.
I want to say that what I've noticed over time, as we continue to nationally speak about maternal morbidity and mortality, I feel that as an inpatient aspect of it in the hospital, that as we continue to talk, that it's bringing more awareness, which is allowing more opportunities for us to implement those evidence-based practices, more opportunities for us to get approval for different programs, or having the interdisciplinary services looking within our maternal world and wanting to come in to help, like Dr. Behrens was saying, getting that access to our patients, being able to do the telehealth, being able to push out education to our parents, our mothers, and our moms after prenatally and postpartumly. So I think that that's us being able to have the conversations, and it becoming a bigger topic is also a good thing, and it's helping us on the inpatient side.
One of, just to kind of piggyback off of what really everyone has said, I think we are starting to see a shift in really pushing for access. I'm going to toot Harris County Public Health horn real quick, but through the Community Health and Wellness Division, we have the Maternal and Child Health Program. We have Black Maternal Health. We have Healthy Start. And speaking specifically to the Maternal and Child Health Program, some of those concerns, Dr. Behrens, that you have about the paperwork process, the getting signed up for Medicaid, for housing, for food stamps, for all of those other things that we need to address first, honestly, before we can even talk about Okay, now we need to make sure we get you to your prenatal appointment. Our excellent community healthcare workers are literally meeting our participants where they're at. They don't want us to come into the home. We will go to Starbucks. We will go to McDonald's. We will go to the library, and we will walk step by step with you and fill out this paperwork. We have a wonderful resource with Civic Heart that helps navigate Medicaid and Medicare applications for our participants as well. I think one of the barriers we found is, like you said, as wonderful as a program as this is, we've been in spaces and they're like, we had no idea y'all even existed. You hear Harris County Public Health and you think of, okay, vaccinations and, mosquito vector, things like that. But there is a shift that is really pushing for access to not just those resources, but like Dr. Barron said, the assistance in signing up and being able to take advantage of those resources. In private practice, I worked with a completely different demographic in lactation. They know what a lactation consultant is. They've read and, informed themselves about the benefits of breastfeeding. Through the health department and through the maternal and child health program, I now get the privilege of literally educating, informing. Every time a mom questions me or says, okay, baby's here, what do I do now? I'm like, okay, if this baby get breast milk for a week, I'm taking it. You know what I'm saying? Versus none at all. But it's these programs and these spaces that are allowing, a completely different part of the population, and the population that is most, adversely affected, to these resources. And so just like we've mentioned before, there are barriers out there for sure. There's the lack of information, the lack of the available resources. Sometimes we have a resource that's really good in January, right? But by the time February comes, they may have lost funding, they may have lost staff, things like that. So we have to be really proactive in continuously engaging with these resource partners so that before we give out a number or a card, we know that if they call, they're gonna get an answer.
I just also wanted to bring light to, as a byproduct of Texas becoming a restrictive state, and I'm not getting ready to get on a soapbox about access to abortion or not abortion, but I just want to have people remember that there's a population of women who are being adversely affected, and those are women who have not been able to carry their pregnancies to term and are having miscarriages, ectopic pregnancies, pregnancies that their water bag is breaking before 20 weeks, and these people are being jostled between facilities because no one wants to touch them because everybody's scared, especially providers, that they will be prosecuted criminally because someone will say that they were trying to provide an abortion. And so there's a whole population of women that are being adversely affected, and it's actually really dangerous. And I just want to make sure that we remember this group of women when we're talking about our maternal health, because these are still maternal mothers, who wanted pregnancies, or some of them may be unwanted. It doesn't matter whether they're wanted or unwanted. They are pregnant and they're having complications of pregnancy, and they're not being cared for appropriately because of a byproduct of our restrictive laws in our state.
And I just want to piggyback on what everyone says. But our biggest barrier is, just like we were talking about, people not knowing about the public health, right? Harris County Public Health have so many services. I remember when we brought the community doulas into Ben Taub to meet. The doulas and the people who are working out in the community didn't even realize that Ben Taub had so many services. They didn't know that they had a prenatal clinic. They didn't know that we had just started a program where we were trying to reach mothers to give them food, at so many weeks. And so it's just, everybody's doing great work, but no one knows that they're doing great work. And so we're like trying to figure out, hey, where are we gonna bring this person? I didn't find out about access until somebody from a clinic called me about a doula. I'm like, I'm not like over the doulas. But because of that, I was able to find other things. So we're all doing great work. How do we get this information to all the facilities? How do we get it to all the private doctors? Like, how do we get it to everybody? Because we're all doing the good work, but nobody knows about it. And it's not disseminating down to the people who actually need it. So I think that's one of the biggest barriers. Like, No one knows about what's going on right here at TSU. Me and Dr. Greeley sitting here like, wow, we didn't know they were doing all of this, right? So we need to be able to like disseminate that information. That's one of my biggest frustrations.
Just related to that, that's something we have a charge to address with that. It's called Greater Gulf Coast Translational Science Alliance, GGCTSA, where UTMB, U of H Clear Lake, TSU, and Houston Methodist are working together. One of our big charges, I guess, is to disseminate information, and we have community engagement people. I would say TSU is one of the experts in community engagement, and that was my question related to, so if women aren't getting signed up, I don't remember who mentioned it, but are they not signing up because they can't handle? Oh, it was Dr. Behrens. Do they not know about the program, or they can't sign up because it's overwhelming? Maybe it's a combination of both, but that's something I think we need to tackle together. But we have the charge, and that's kind of actually it's Dr. Poon's in my area for resources and services for that grant to work to figure out how are we going to disseminate that. We've already kind of talked about some potential ideas. So one is working with community engagement, like TSU does, getting like this, just working with the community to talk about things. And the many things that Dr. Pounds and other people here do to work with the community to get that information out there. Another is partnering with media and getting on, can I even say TikTok? Is it banned or not banned? So social media. And, so for the various, I guess it's split by age group. So for me, that's Facebook. But, so whichever, social media you use, can we use social media to engage? Many of my medical students are doing TikTok projects. That's like the really popular thing to do. And a lot of the younger women are using TikTok to get all of their medical information. Can we use something like that to get information like public service announcements out? So that's, I think, such an important question, because that's also happening with when we talk about other things like in research translation, like for HIV prevention, or earlier someone was talking about her patients who had syphilis and then congenital syphilis. Syphilis has gone up like 1,300%, and I think people don't realize that. Well, my early work was in HIV prevention. And we have, over my 20-plus year career, we have actually developed HIV prevention or PrEP. But you know what? Only about 15% of eligible women use it. So we have a big issue there. We have this, and people aren't using it. So we're having to rethink the way we do things. We have all these services. We need to partner with people, marketers, media people, community engagement, to figure out how we get the message out. I think that's a critical question, because we can talk about what we can do and make great programs, but if people aren't going to use it, we can make great drugs, great prevention, great devices, but if people aren't going to use it, we're just spinning our wheels.
That is so true. Okay, so the next question is, what is the process for recommending social or additional services for your patients at your practice?
I can speak to that. So the process, so again, I'm in private practice. So the process is just either the midwife that works with me or myself, so the providers, just identifying patients that we think may need a certain resource, or just at, like if it's pregnancy related, then at like the first or second prenatal visit, just letting them know what resources are out there. And so, but what I also can say, and I was gonna say that to the last question as well, but I think it can be sometimes overwhelming when you go to, and I think a lot of us can identify with that at that first OB visit, they may give you like a little book, a little folder, and there's like a million flyers in it. Half of those flyers are going in the trash, okay? Let's just be real. So I think at the end of the day, I think sometimes we do too much of passing out literature instead of actually sitting there and carving out time in the appointment. Like, look, I'm going to go through some of these resources and talking to our patients instead of just handing them stuff and walking away and expecting them to read it. And it's not because they can't read, it's just more so about finding the time. And I know when I go to the doctor and they give me a packet of stuff, it's going in the trash, like a lot of times. So I think it's important for us to have the conversation, talk directly to our patient, the providers talking directly to the patient, or if you have a social worker, like in some of these different, the bigger clinics, if you have a social worker there, but offering patients to meet with the social worker to actually sit there and describe some of the resources that they may benefit from is important. And then again, social media, when you ask about how I do it in my practice, I do a lot of education through social media, and it is very helpful. I have patients that haven't read a bio on me, they don't know this or that, but I follow you on Instagram, I saw this, I saw that reel, and that's where things are moving right now. TikTok was used, which I don't know if it's going away or not, but it was used more than Google in the past couple of years. So it's like people are going to social media to look for certain things when they have something, like if they're bleeding, instead of calling the doctor or calling 911, they're going to social media, pregnancy, bleeding, and they're looking to see, and a lot of times there's misinformation on the internet as well. So having more qualified people actually making social media posts about those things so our community can be educated is important, and that's something that I've implemented in my practice.
One of the great things about Nurse Family Partnership is that we're seeing the client for about 2.5 years. And so we're going out there once or twice, either once every week or once every other week. So there's a continuum of care. And so we're able to ask them questions about, what's going on in their life, what do they need, what are some of the resources that they're lacking. And so the nurse, we have a lot of resources that we're able to give to the client for whatever she's lacking or whatever she needs. Sometimes it's a little bit of a push that you have to give to the mom. It depends on what the need is. If it's desperate enough, we don't have to push her. All we do is just give her the information and she would call. And in other instances, if it's especially if it's something like mental health, if she's not necessarily in a crises, but she needs mental health, we may have to push her into that by sitting there while she calls the people the resource that we gave her or something along those lines. But we're able to continually, every visit, ask her what's going on in her life. We can sometimes walk in the home and see what she needs. And so we're able to connect them at every visit if we have to.
At Legacy, we have prenatal navigators. So we have most of our clinics have walk-in pregnancy testing. And so during that, while we wait for the test, we have the navigator to kind of go over some of that programming, those other resources, do those other assessments to connect that patient to other things and help plan out what might be a pregnancy. I think the other thing we do is our clinicians. So they are, again, universally screening. So every time you come in, we're going to ask, even though we asked you this question 2 weeks ago, we're going to ask the same questions just because something might have changed. And even if maybe that particular time it hits differently based off what's happened in the last 2 weeks or last month since I've seen you. And so I think if we can get better about universal screening, which, earlier we were talking about bias, we might assume that nothing has changed in the last 30 days, and so we don't ask that question. But asking that question a third time, just hits differently. Oh, yes, I am experiencing intimate partner violence, or I am experiencing homelessness. I didn't want to show you before because I was scared. So just recognizing that consistent asking provides the opportunity to develop that trust and rapport, which we haven't talked about today just yet, but I know that consistency allows for trust and rapport for people to open up about the other things going on.
That consistency, William, is definitely important, and I'm so glad that you brought it up. When we have a participant that enters into the maternal and child health program, they are assigned to a community healthcare worker. This will be their person. They're not bounced around. There's not someone different that they speak to every time they need something. And then also above our community healthcare coordinators are our social work supervisors, because sometimes the social determinants are food or clothing, and those are things that our CHCs can tackle with their eyes closed, right? Other times they're a little heavier. You know, there may be a CPS case. There may be a court case coming up. There may be a heavier social issue that is at play, and that's when our social work supervisors are able to intervene. But to William's point, each time, whether it's our community healthcare coordinator, whether it's me, the lactation consultant, whether it's our program managers, whether it's our social work supervisors, anytime we're interacting with the participant, whether it's in their home, if they come and they engage with us at an outreach event, we're going over that checklist. Hey, how you doing? What's going on? Has anything changed? I know last time we talked about this. What have we done to address this? Have you called? Why not? You know, things like that, establishing that rapport, establishing that trust so that if something does come up, they're calling, they're texting, they're like, hey, I need you. Also, I think it's really important that that referral process is seamless, right? Like a lot of people have stated, nobody wants to have to fill out a form every single time they talk to somebody and go home with a million different things to read. As our community health coordinators are going into the homes and going to these visits, as they check these boxes, as they assess these situations and these family dyads, we're referring out. We're going to Black Maternal Health. We're going to Access. We're going to all of the different resources within the Harris County Public Health Department for the participant. We're not giving them the pamphlet and saying, here, call this. We're putting the referral in, and then someone from that department is reaching out to them. And again, it's not to say that it's not something that they don't want. It's not to say that they're illiterate, that they can't read, that they're uneducated. They're overwhelmed. I got to pick up my kid at 3. I got to have dinner on the table by 6. You know, there's a lot going on. So sometimes just really establishing that rapport, easing the process of learning these social determinants and things like that, the trust that builds between you and this family, it's mind-blowing. We have so many testimonies of families who started in our program, have been in for 2 or 3 years. They've gotten, degrees and licenses and GEDs and jobs, and it's amazing to see. But it starts with those little things that we kind of overlook sometimes.
I just also wanted to echo a theme that I keep hearing, is who is a member or who all are part of the team for the pregnant and birthing person. And this team is constantly expanding because we realize that the clinician can't do it all, the lactation person can't do it all, the community health worker can't do it all, the social worker can't do it all, the person who's registering them at the front desk can't do it all, but we all have to be there to catch as the person doesn't fall through the cracks. And so whatever moves forward from these discussions, I do want to make sure to bring emphasis to the birth team or the team that is helping to care for the mother, because it is overwhelming and the mom can't do it by herself. And the more that we the more that we victimize the victim and say, why didn't you do this? Why couldn't you do this? Why couldn't you do this for yourself? We're just gonna stay in the same state, as opposed to saying we, the team, the community, that everybody needs to take ownership over these pregnant and birthing persons so that we can help make sure that they are successful, that their babies, their infants thrive, and all of these things, and it will make our community greater. So I just want to kind of bring light to the theme that we keep talking about, is this team and how we expand that team and make it an integral part, because I can say, even though I think we do an excellent job in Harris Health, every person doesn't have every member that we are talking about today as a part of their individual team. The resources may be available, but every person is not getting a contact from every member of that team that we're discussing today, and that may be something that we all need to look at in the future.
Yes, that is so important. So my next question is, does your organization assess non-medical drivers of health for patients, and how effective has this been?
So yes, we do here at Legacy. I think what was a game changer for us was when we switched to Epic, because what came from like just being a satellite program was universal across all our clinics. So what people may not know, we also have some school-based clinics as well. which allows us to assess Johnny, Susie, whether, coming into from class, and then we're also able to follow with mom afterwards. Hey, you did your pre-screening ahead of the visit. We want to follow up with you about what's going on. I think what's been a challenge is the space, because that clinic visit is 15 minutes, and there's sometimes pushback about what is more important. Is it more important to do the medical side or the social side? And we sometimes compete amongst ourselves about how much space, how much time we give with that patient. And the patient, as we said earlier, it gets overwhelmed. Like, well, what do you want me to do? You want me to focus on food? Want me to go to this visit? Do you want me to exercise? Really helping, we're competing amongst ourselves. So I think with more universal screening, I think we can do better by figuring out when is the best time to do that screening, and then what also hasn't been finalized is how often to do it. So do I do it every visit? Do I do it once a year? Do I do it every 6 months? Do I do it every time I come in for my pregnancy, prenatal visit, and so forth?
So in our program, we definitely assess and address the non-medical driving factors that can affect our families. I think that for those of us who are in this field, we're all learning and beginning to know that we have to encompass all of that. We can't just look and say, okay, you need to be at your appointment at 12:30. You need to breastfeed your baby every 2 hours. We have to be able to assess what is going on in the home, what is going on mentally, emotionally, socially with these families in order to really be able to design a care plan specific to them. Because one care plan for one family may not apply to another family. And I think addressing those non-medical driving factors, it also helps foster that sense of trust and that relationship, because the family now sees you as not just somebody that's going to give them a checklist of things that they need to do and kind of tell them what to do, but actually as someone who is really invested in not only what they have going on in the moment when it pertains to the pregnancy and the birth of the baby, but also how their 5-year-old is doing and how their mother or father that they may be taking care of in the home are doing and things like that. So we do assess and address those non-medical driving factors. And another wonderful thing that the Harris County Public Health Department has developed is the Maternal Health Bill of Rights. And that is something that we are really pushing. We're getting out there. We have Z cards out at the table in the lobby, but it's a little card, and it is passed out to everyone. It's not huge. It's not something you can't fold up and drop in your bag. But what it does is it empowers people. I'm all for educating and empowerment. I don't care what decision you make, as long as it's an educated one, right? And through knowing that we need to address these non-medical driving factors, and through the different programs that are offered under the public health umbrella, and through things like the Maternal Health Bill of Rights, like the MH Reach program, these are the tools that are assessing and making our families aware, like, oh, okay, this is a thing. I can ask this question. I can advocate for myself. So it can turn from us assessing them for their non-medical drivers to them already being able to recognize, oh, okay, this is important too. This may not be my blood pressure, but this is equally as important. And I think encompassing that is just beneficial all the way around.
I was going to say that we have a resident and fellows who have gotten a President's Cabinet Award or an internal grant funding that's not a large amount of money, but enough for us to initiate the program that is looking at social determinants of health. And kind of what I mentioned earlier, to institute that program, and then also to start a centering pregnancy program. And I wanted to ask Renee about your program, where you had mentioned that you have the centering pregnancy program. If that, because it's kind of a longer format, and the person who's leading that group, if that gives you more opportunity, because I think that William had mentioned that that's an issue, and we find that as well. There's just not enough time in the visit to kind of go over that every time. Are you finding that you have more time to kind of find those kind of things out or to explore that? Or as someone else mentioned, you don't find out, until maybe the third time you ask that they are having these issues because they don't feel comfortable telling you. Like, do you feel like the centering pregnancy helps you with some of those issues?
Well, the centering program is conducted in the clinics, so prenatally.
Yeah.
And so it does give them an opportunity to have a community of mothers and have those discussions. So those questions are being pulled out. I will refer back to Dr. Greenlee and Dr. Behrens to see if those questions, do you all see that they're being able to get the answers to the questions that they need throughout their prenatal visits?
Well, I just want to say for centering in Harris Health is led by our certified nurse midwives and not our physicians.
Right.
One of the barriers that we have is that it's not in every single clinic. It's only where our midwives actually do. And so they spend a lot of time with them. They do their prenatal. And y'all talked about the group. It's like the prenatal care is done in that group with those groups of ladies. And so one of our barriers is that it's not in every one of our health centers, which we've tried before to get more funding to be able to do that and spread that out. But they do get a lot more time. They do get a lot more time. I'm not sure if they get the social determinants.
I was going to say that each centering visit has a focus. I don't do centering, but our midwives do, and I work closely with them. And so each centering visit has a focus. And so, whether it's diabetes or lactation or social determinants, each visit has a certain thing that they're supposed to go over. But I think the beauty of centering is that it builds the community. And so if a woman, just like William was saying earlier, maybe it doesn't come out on the first visit, but maybe 3 visits in, they feel more comfortable with the community, or they may be chatting with other women that are in the centering group, and another woman identifies an issue and may encourage them to bring up. So that community that is being built, I think centering pregnancy does help with that. One of the things that has come up is centering sometimes is more, inviting to some ethnic communities and some not. And so culturally, people may want to tell all your business in front of other people, and some people may not. And so it works well with some groups and maybe not always with others, and ages and demographics. So that's something that has to always be considered. The other thing I was going to say about the social determinants of health is that, yes, in Harris Health, it is a part of our EPIC, and yes, there is screening. But then I think where we are still trying to get to the next step is after the screening is done, who's going to take ownership and make sure to do the follow-up with the screening, and the time that came up before of the time that the clinician actually has to do the screening and the competing time. So
I agree, and I think we do a very good job of screening. I agree with the concerns after the screening. The other thing that I just want to bring up for thought, I have no answer. But when we look at the screening specifically related to intimate partner violence, the screen positive rate is exceedingly low. And we know that intimate partner violence is not as low as the screening would suggest, but we also understand that that's not something that's easy for patients to disclose. And I have no answer, but I think that that's worth at least thinking about.
I think that in the realm of trying to find the time and the space to deal with both the clinical and the social issues that may be impacting our families requires us to think different about how we've been doing things. I have found that specifically with certain cultures or with certain demographics that are very private and very separated as far as gender and sex goes, it is often better, I get a better reception, I get a better engagement if I go to them in their space, right? We have to start utilizing our community centers. We have to start utilizing our community groups so that they can bring these people together and that we can go to them. Clinically, yes, things have to be done in a certain space, absolutely. But when we start trying to address social issues and when we start trying to build that rapport, we do have to face the fact that a lot of times we may need that space for a televisit. We may need to utilize that space for a community or a group setting, and sometimes an exclusive community or group setting. One week it may be African American moms, another week it may be Arabic moms. We have to be able to go into each of these spaces and provide what each of these demographics need. We can't get caught up in, oh, they didn't come into the clinic and do this assessment, so we have no way of helping them or assessing them. We have to be able to think a little different and utilize what's already out there. I wish we could build a clinic next to every school, a lactation room next to every pediatrician's office, but we can't, right? But go into your communities, your churches, reach out to these community organizations, these faith-based organizations, the mosques, the temples. Do you have pregnant moms here? Do they have concerns? Do they have questions? Go into those spaces. That way we meet them where they are. And 9 times out of 10, they're way more comfortable when they're in their spaces, surrounded by their peers, in answering those questions.
Just to echo that, a few ways of possible solutions. So at Legacy, we actually use student interns and AmeriCorps members to do some of that screening and then linkage to resources. So typically an intern might be with us for a semester. We do a quick weekend training with them about how to do it. Our AmeriCorps members are with us longer, as 9 to 12 months, so we're able to do more complicated training to help triage them to resources and things like that. Definitely a great way to address, earlier we were talking about implicit bias, so before you become that clinician, before you go off to become a public health professional, we're going to ground you in how to actually talk to people who are receiving your services. I think the other thing, too, about screening, we actually did 2 pilots. We did a pilot with just our interns, where our interns weren't expected to ask the question directly to the patient. They were expected to give the screening form to the patient patient fills it out on their own and returns it back. We also had our MAs do a very similar screening, asking the patient directly. Our positivity rate was noticeably different. So when people are able to self-disclose, they're more likely to be honest than if you're going to ask the question directly. And so that's where we're trying to get to Legacy. We just switched to Epic. It's been a challenge, a learning opportunity. And so we're hoping to, hopefully in the next 12 months or so, implement more self-disclosure. Like, we're going to give you the screening form ahead of your visit. You fill it out. We will touch bases when you come in or ahead of your visit before we just ask the question directly. And I think that to the intention behind social screening is to actually help people versus just screening the screen.
Yes, that is so important. So we're going to go into our last question. So based on this conversation that we've had today, do you think a culturally competent toolkit is needed? Why or why not? Do you think it should be, what do you think should be included inside the toolkit?
I definitely feel like it's needed. Some of the components of a toolkit that I would like to see, aside from resources for both clinical and social non-medical driving factors like we've talked about, but also encompassing, right? We have to be able to put in this toolkit tools for the north side, for the east side, for the south side, for Galveston, for Baytown. I really think we have to do a lot of work, of course, and make a lot of connections, and in order to push the idea of not working in silos and building those effective teams that can really help take care of these families is going to require us to cover a lot of ground. We can't stay in our comfortable jurisdictions and in our spaces. We have to be willing to engage so that if we meet a mom that lives across town, we're like, oh, well, sorry. The only way I can help you is if you get to this clinic 2.5 hours. We have to be able to provide a resource that is feasible for them to use. In that toolkit, I would also like to see the utilization of our community healthcare workers and coordinators. These are the boots on the ground. These are the people that can step outside of the clinic and can step outside of the hospital and meet the families where they are, can help them with that paperwork, can help educate them on the importance of getting to your appointments. We are I know Veronica was here earlier with the American Heart Association, with the Mom RX program. All of these things, these people aren't coming to the public health department and to our office to get, these are all things that are being deployed out in the community. And so I feel like while we assemble all of these resources, from OB-GYNs to therapists and psychologists and psychiatrists that can address Black maternal health, to dietitians and nutrition, to vaccination access, to sexual screenings and prevention and treatment, all the way to doulas and midwives and lactation consultants, or peer counselors or lactation counselors, to community healthcare coordinators. We also need to make sure that we build a toolkit that can address the entire Houston area, so that we can direct them to places that are close to them and convenient for them.
I think also, I think trust building is really important. What Dr. Nicole Lee Plenty had said earlier today about neonatal survival being better for Black neonates if they had a Black provider. Like, to me, that, well, first of all, I want to understand why that is. Like, I think it's important, like the 360-degree turn, but that's just how my brain works. But trust building is part of that, because it's like at some point we will have enough providers to meet that need. So that's, that's basically like training the people. But until then, until we have that, we need to build trust. And so as a white person, how can I be considered trustworthy when I have an African American patient who just meets me? Like, how can I establish that trust in, like, when I'm not in charge of my schedule and I work for, someone who's determining my schedule? How can we do that like that? I mean, you don't have much time. And so how do we do that trust building? Because it starts like before the patient ever comes to see me, their interaction with the scheduling process or the web page or health grades, or however or if the person had a fight, the patient had a fight before they came in, or they had their blood pressure taken and it hurt their arm. It hurts my arm because mine runs high. Things like that. Or if we just have different forms of communication, like there are a lot of different things that affect the trust. So I think that's really important, just helping us understand how culturally we may communicate differently, or our body language, how that may just be different. And I may just read something into something that means not what I'm thinking it means at all. I think another thing would be scenarios that could be either like written out by, like, I think Jasmine had mentioned like storytelling, like a scenario that where maybe the patient comes in and is afraid because they've heard all these stories from their friend, and they're afraid they're going to get diagnosed with a specific cancer because they had a friend who had pain, and they're having pain, and they're afraid to come in, and that's their issue. Maybe it's not that they don't trust me, maybe it's that they're afraid. And so just like having, like, understanding where the other person is coming from, and for the patients to understand that, I only have 15 minutes for this visit, so we can just understand each other. I think that's an important part of that toolkit as well, just increasing communication and understanding, so we can limit the times of misunderstanding or making assumptions or having unspoken expectations become unmet expectation and disappointment and frustration. And so I think, I wrote a whole page and a half about this that we can discuss later, but those are my high points.
Obviously, yes, we need a toolkit. A couple of things that ring out to me is making sure that before the patient comes, I guess from the toolkit or wherever they're getting their sources, that they know what to expect, like you're saying, Dr. Vincent. Who's going to see me? Who's all a part of my team? They are going to ask me all these very personal questions because a lot of times patients are, I think, shocked that we're asking these very intimate details of their lives and maybe a little bit defensive because they didn't even expect us to be asking these questions. So just managing or helping them to know what to expect when they're going to come for the visit. Like I said, who is a part of the team? I'm going to reach back to what happens if my pregnancy doesn't continue, and those moms, who are grieving and having pregnancy loss, and not forgetting those moms. And then, of course, the connections of how to access the resources, but not just how to access, but how to navigate and get the access and the care they need after we identify all of these social drivers of health.
I think in addition to a toolkit, we also might explore policy solutions that support engagement in maternal health. I've had many friends become pregnant, start a family, and they have disclosed it's a struggle, especially regarding maternal leave. Like literally, it's something like I got a paycheck cut where I'm not sure how I'm going to pay rent because I've had, I took my paternity leave that ran out, and then I was on FMLA, and so just recognizing and these are, professional people. So I imagine someone who doesn't have a professional job where they have that built-in paid time off FMLA, like how are you paying rent? How are you paying your mortgage? If you have to, do all the things, right? That might be medically necessary for me to do as well, right? I need to go to these visits for the sake of my life or the life of my child. And so I think some of the policies and missing don't allow for people to fully engage in the process where they're going back, well, do I pay my rent or do I go to this medical visit? Do I put food on the table or do I go to the medical, really having people make those choices.
I know one thing with the California Collaborative, because I've looked through it also, is the number one thing is access, right? And looking at Texas legislation, seeing what is covered and what's not covered, because we can come up with all these great ideas. However, if the legislation or if the policies that are here in Texas hinder us from moving forward, we have to acknowledge that there's some issues with that part too. Like they spoke about with your insurance leaving in 60 days, right? And then now you have to find something else. Medicaid did expand for 12 months, but if you are not a U.S. citizen, it doesn't expand for you. And so those are some of the things legislative-wise, access to care, that we have to really, in the toolkit, because one thing that they did in California is they got insurance to cover more, right? And so we have to make sure that we're going to our legislation in Congress and making sure that in Texas that the things that Medicare covers for in this state too, which I think is going to be an uphill climb. But, so, and I will say for Legacy, Bentai, we appreciate y'all getting on Epic, because Lord have mercy, that was the hard part. I just wanted to put that shout out because I was like, thank you, But yes, so that's what I think we should add to the toolkit, because the toolkit has a lot of information on that.
And I think to that point, I think if we could see each other, if we could see the patient from a different lens, I think we could be more comprehensive. And so that allows for the clinical institutions to see a patient. Oh, you went to Bentab, you've been a Methodist. But if you are like a social services provider, how would I know this patient was in the hospital last week unless they tell me? How would I know this person told the doctor they're experiencing intimate partner violence and they're showing to me not saying anything? So I think if we could have almost like a web of access. I used to work in homeless services, and what was great about there was we had the same universal screening that we were doing. We could see that patient. We can see that you've been in all these places. Not that we're going to, call you out on it, but, it allows for us to, be more empathetic to you. This is not your first rodeo with homelessness. And so I think being more empathetic and, addressing some of that biases we talked about before allows for us to be just more responsive to when they are in front of us.
Is there like the electronic medical record, like you're speaking of? Once it's everywhere, then it doesn't matter if you go to Methodist, if you went to Herman, if you went to Ben Taub, we can still see your record.
Another thing that I think would be helpful in the toolkit would be a technological aspect. As we deal with the younger demographic, and social media terrifies me. And it's only because there's so much misinformation. Like there's, you see somebody post something and they say something and it's purely based off their personal experience. It is not evidence-based. It is not, researched. And sometimes it's dangerous. But I have the privilege, I can't recall her name, but I know the name of her organization is called Shiro Nola. And she's a physician who completely stepped away from the clinical aspect of practice and moved to California, moved to Silicon Valley, and literally created an app. And this app she took back home to New Orleans, and she utilizes this for pregnant moms and their families. It's a concentrated space. They do a lot of things virtually, so that ties into being able to conduct in those spaces where we may not have the space or the time in a clinical setting. So I think we, again, back to just kind of thinking a little bit differently how we do things, we have to get on the technology bandwagon because it's coming, whether we want it to or not. And I think if we can curate it and create it the way it should be, then it's going to be much more helpful. And then lastly, I just would like to see a research component. In this, I think in the toolkit, if you're a resource or if you're a provider, if any kind of capacity, throw something about a research study, throw something about a research program. We do not participate in studies. And not to get on a soapbox, but with all of the cuts and things that are happening, we may not be sought out to participate in studies. And there is no way of knowing what is working, what is not working, if a medication, a program, or anything is going to work for our Black families unless we are participating in this research. So I do think that that's also important to include in the toolkit.
Okay, thank y'all so much for y'all input. This was personally so eye-opening. I learned so much sitting up here listening to all of y'all. And thank y'all so much for being here today. We truly appreciate your time. I'll now pass this to Dr. Olaleye.
Wow, I'm just blown away. Okay. Thank you, everyone, again. Let's give it up for this amazing team. And by the way, I texted Dr. Ajewole and said, this is our strategic group. This is the group that's going to move the needle in Harris County, Houston, Galveston. And we plead that we would work with you. You guys are amazing brains. And I'm just like totally I was trying to take notes. And I know Jasmine took a lot of notes as well. So thank you so much for what you're already doing. But coming out here and contributing, these are like major contributions. When we got the grant, I sat with, I think, Jasmine and Cecilia and told them, we're not going to reinvent the wheel. We'll go around the country and see, what's working and look at parts of the country that looks like us. Don't just go to big California, go to those places. And I'm so impressed. Let's give it up for Jasmine, Cecilia, Kennedy, and Grace, our postdocs, CHWs that really, took it to another level. So please, we will be reaching out to you to serve in this capacity. We're still going to come up with a fancy name for it. But thank you so much. And that's all I have to say. And thank you, Dr. Poon and Dr. Ajewole, for leading our CEC core and hosting this conference with your amazing staff, Dr. Ogbo. Thank you so much. Thank you. I'm super blessed to be part of this great team. And all our partners, industry, governmental agencies, community members, CBOs, FBOs, we will be going to the churches, the mosques, the temples. We will go there. We will come to them. So thank you all for coming out. I believe this is a great success. This is a big step moving forward, and we all will move the needle by God's grace and reduce maternal mortality in Texas and in the country. Thank you.
Thank you very much, Dr. Lale. Please give yourself a round of applause. Thank you so much. Sorry, I have to change to my Kenyan feet here, if y'all are wondering. But thank you again for engaging with us. I am beyond excited to see the information that was shared today, and not just what was shared, looking at what will come out from this, information. I'm looking forward to putting the toolkit together, and like Dr. Laleye said, us, having an opportunity to gather again and have this strategic planning. So we could not have done this without each of you giving your time and your expertise, and a big thank you. Thank you all so much for joining us. Community members, everybody online, this has been amazing. We have already shared a lot of save the dates for future events. We look forward to you all continuing to engage with us, and a big thank you again, and God bless us all. Thank you.